audio and versus written interventions and perceptions about leprosy in Nigeria. So we greatly appreciate the presence of the following. The Director of Public Health, Federal Minister of Health, Dr. Chukwuma Anyike, who has graciously spared his time to join this webinar. So we welcome Dr. Chukwuma Anyike, and in a short while he will be making us some remarks to us. And I also want to recognize Dr. Orioke Ochuko, is a Deputy Director in the Federal Ministry in the Department, National TB Leprosy and Bleeding Control Program. He's here representing the National Coordinator of NTBLCP, Dr. Labaran Shehu, who is unavoidably absent. Also, we want to welcome our own, the Red Aid Nigeria Chief Executive Officer, Dr. Daniel Ebule, and the Executive Director of LTR, Leprosy Relief and TB Initiative Nigeria, Dr. Dahiru. Also, I want to welcome the founder, LRI. Very shortly, Krista will be making some comments on behalf of the founder of this project. LRI, Leprosy Research Initiative, is the founder of this project. Also, the program managers of Cross River and Taraba states where this project took place. And we also welcome the representative of IDA Nigeria, and then all of us to this project. So we are all welcome. And I want to quickly request the Director of Public Health, Federal Minister of Health, Dr. Chukwuma Anyike, to please kindly give us an opening remark from the Federal Minister of Health. Thank you, and over.
Okay, so thank you, Dr. Charles Mwafo. And I want to congratulate everyone on this call. And for giving me the opportunity to make these remarks. This webinar is coming at a very important period, just as the Federal Minister of Health and Social Welfare is gearing towards changing the narrative and the health sector in the Federal Republic of Nigeria. If we have listened attentively and followed the activities in the Federal Ministry of Health, for the past 1 year, we've been trying to bring up innovations, towards improving the health outcomes in Nigeria. And so it's coming at a very important period. And another important aspect of this webinar is that it's speaking to the principles of primary health care on which our health system is built on. Primary health care definition has a very important component that has to do with community engagement, community participation, and community empowerment, which is a very sure way towards ownership and sustainability of any interventions, be it communicable or non-communicable disease. And so, we will have any other word at this moment than to congratulate Red Aid for taking these bold steps, which runs in accordance with the leadership push in the Federal Ministry of Health. We realize that you won't be able to effectively and efficiently control any disease without carrying the communities and empowering them. We have been doing certain things, but now we want to, it has worked, it may not work, but now we want to run with something that works. We have been given many senses, at least 6 of them we are sure of. But you know that what you read, what you hear, and what you feel are very important, the very key components of you being able to follow and understand and have your own conviction or perception. And so now we want to move into another aspect, probably to help us, which I know by the end of, at the end of this webinar, we'll be able to find out with evidence that this aspect of audiovisual is very important and should not be played down on if we really need to empower the communities. And so for us in the Federal Ministry of Health, we think that this is a very good innovation and we want to launch on it. And like we said, normally, if you carry the government along in any of your operational research or implementation science research, you are sure of making a change in the policy direction of the country. So the assurance is that whatever that comes out of this research, we will use it to tweak our strategies towards changing the health sector narrative in the country. So, and it also runs in tandem with the 4-point agenda of this present administration. Number 1, speaking strongly about leadership and governance. The second one, talking about putting everything, every measures towards improving the health outcomes. And I think that the outcome of this research will help us to anchor very strongly on the second agenda of improving the health outcomes, especially as it concerns leprosy, TB, and other related diseases that this division is controlling. So I want to congratulate VetAid. I want to congratulate every person, every stakeholder that has put in his sweat to make sure that will come to this arena now. And most importantly, for the funder that have been able to put funds aside to ensure that we will run with the global push of generating evidence that can help us to put more and to scale up, with what works and to drop those that will not work. So we are excited from this angle, and we are looking forward to supporting any other partner, any other organization that will help us in our struggle towards changing the health outcomes for the people of Nigeria. For the want of record, let me just state the remaining 2 agendas. The third one being unlocking the health sector value chain, because we feel that, we should be able to have our own in terms of manufacturing of drugs, in terms of manufacture of the healthcare commodities. And the government is coming up with a lot of pronouncement to make the environment conducive for private sector to invest on healthcare delivery in the country. Of course, the final one is improving the security, of health security of Nigerians, to have a very good, healthy Nigeria. So, for want of time, I want to congratulate all of us. I want to congratulate VetAid for this bold step. And I want to use it to challenge any other partner, who has the enablement to put in more towards coming up with evidence. And that is what we can use to change the narrative in the healthcare delivery in the country. So thank you very much. And I hope that at the end, we will justify all the efforts and the funding that has gone into this particular research. Thank you, and over.
All right. Thank you very much, DPH. Your words are kindly well taken. You talked about, getting research into policy and practice. We believe that the outcome of this, the findings of this research, will be, going to bring a policy brief to your office so that you can get it into policy and then practice in Nigeria. Thank you very much. I also want to please, we have to allow the federal government to give us their agenda in health, especially the 4-point agenda by the Honorable Minister. Please, the rest of us, we want to limit our comments to about 3, maximum 5 minutes, so that we can go into the meat of the agenda. So on that note, I'm going to call on the representative of National Coordinator, present here, Dr. Uruko Chuku. Please, you have the floor, 3 minutes.
Okay. Thank you, Dr. Wanfo, for the excellent coordination of this webinar. Good afternoon, distinguished ladies and gentlemen. I want to join my boss, the Director of Public Health, the Federal Ministry of Health and Social Welfare, to congratulate Red AIDS for this very epoch intervention, and for all the efforts that you supporting to help to see how we stamp out leprosy from Nigeria. We are really excited to be part of this innovative project, because we know that it can help in improving the behavioral components of our response as a country, not only for leprosy, but also for other health conditions, as is been highlighted by my director. This your work completely aligns with the strategic vision of the government of Nigeria, and we know that it will really be pivotal in helping to shape some aspects of our response as a country. As we strive to achieve the Sustainable Development Goals, we think we can continue to work to see how we really come up with innovations like this to really help to provide health education messages that are context specific for our people, so that we don't just copy and paste as a country. So because of that, we are fully in support of this, and we know that we'll be able to learn a lot from this meeting this afternoon that will help us to further improve or strengthen leprosy control efforts as a country. So without taking much of our time, I just want to appreciate all stakeholders that made this project to be very successful. I want to thank Red AIDS for really executing this project with tact. All the ILEP partners, I'm sure you contributed one way or the other. I mean the other ILEP partners, the states, the state governments, both Cross River and Taraba. We appreciate their effort in seeing to the success of this project. Every partner that contributed to this, we appreciate your work. Not also to forget the persons affected by leprosy, represented by IDEA. Just to round up by saying that the NTBLCP and the government of Nigeria, has been stated by my director, is very committed to implementing all relevant learnings from this project as we look forward to improving our overall health response as a country. Thank you and congratulations once more.
Thank you very much, Dr. Urieke. Yes, I know the NTBLCP is always with us, and always with NTBLCP in our pursuit to eliminate leprosy in Nigeria. So thank you very much. Quickly, I will go to my Chief Executive Officer, who is now going to, who are going to give us a welcome address before we continue.
Thank you, Dr. Nwafo. Good afternoon, everyone. Good afternoon, Dr. Anike. Good afternoon, Dr. Ochuko, and everyone. Let me stand on the existing protocol to welcome you all to this webinar. Special appreciation to the Director of Public Health again, Dr. Anike, for his support to Ready Nigeria and to the ILEP family to ensure that we try to meet our zero leprosy goals and objectives. To the National TB and Leprosy Control Program, we are always your partners in progress. And to the ILEP family, we'll keep working together to attain the zero leprosy goal. I can't also start without also thanking LRI, the Leprosy Research Initiative, and our co-partner in implementation, Leprosy and TB Relief, for ensuring that we're able to successfully implement this very important project. Again, let's not forget our colleagues in Germany, GLRA, who provided technical support and other forms of support to us in the process of carrying out this intervention. I'm proud to welcome us to this webinar. It's an important webinar to discuss the intervention, the audio written intervention, which, of course, I've mentioned before, was supported by the Leprosy Research Initiative, ran for 2 years and has graciously come to an end. In doing so, we're able to one of the key issues of this project was to address the perception of leprosy among the population in Nigeria, keying into 2 states, Cross River and Taraba states. And we were able to reach out to over 2,152 health facilities and deploy over 450 solar-powered MP3 players so as to get people's perception about leprosy, both the literate and the illiterate population, so as to try to reduce poverty, stigma and discrimination in these states, and of course, by extension, by the whole of the country, Nigeria. We all know about the effect of leprosy stigma, which is still quite high, which is one of the key objectives this project aims to address. And we hope that this would also key into the national policy documents for leprosy, the zero leprosy roadmap, so we can ensure a significant reduction of leprosy stigma and discrimination in our communities and in Nigeria as a whole, which is a hindrance to hitting our zero leprosy targets. Thank you to all the field workers who participated in this research, to the Ready Nigeria team that tirelessly worked night and day to ensure that this project was successful, and we're also at this point disseminating the results of the project. Once again, welcome to the webinar, and I wish all of us fruitful deliberations. Please pay attention and enjoy all the presentations we will have. Thank you. Over.
Thank you very much, our CEO, Dr. Ebule. I will also quickly request Dr. Tahir, who is the Executive Director of LTR. LTR is a partner ILEP organization in Nigeria that also coordinated the research in Taraba State. So he will give us his welcome remarks. Please, Dr. Tahir, over to you.
Thank you so much, Dr. Nwafo. I start by thanking God for making us see this day successfully. And I also thank the DPH for, despite his tight schedules, he's able to be part of the webinar. And that, of course, proved to us his purposeful leadership since inception, since national coordinator now as DPH. Dr. Ochuko, welcome, and also thank you for the support so far received. I want to appreciate the Red 8 Nigeria for being very flexible and forthcoming in implementing this project. My thanks will go to LRI for giving us the opportunity to implement the project in Nigeria. And then also to the Taraba and Cross River State Program Managers. Thank you so much. Above all, persons affected by leprosy have been very wonderful and very supportive. So thank you so much, and I hope what we will discuss will be very useful. Thank you, and over.
All right, thank you very much, Dr. Tahir. It's been wonderful working with you all these years, you know, and from NLR days to now LTR. Yes, at Cross River, do we have any representative of Cross River? Can you just give us a word in 1 minute? The program manager of Cross River? Or his representative? Taraba State? All right, thank you. Maybe then we also have the representative of IDEA, Peter. Peter, please, 2 minutes.
Thank you very much. I thank God for this opportunity for me to be in your midst this afternoon. I want to appreciate Radiate Nigeria for the work that they are doing in order to better the lives of persons affected by leprosy in the country. I want to also take this opportunity to give thanks to the federal government, Ministry of Health. The team from the Ministry of Health this time around, they always be up and doing, and I'm very sure that in the nearest future, by God's grace, everything will be put in place and things will flow. And the problem we are having now, they will also tackle it. The most problem that giving us sleepless nights as persons affected now in the country is the lack of drugs. But I'm trusting God that it will be a thing of the past by His grace. So thank you very much. I'm happy to be here. And going through that, I'm very sure that we will be better more than now. Thank you. God bless you.
Okay, thank you, Peter. Now we'll go to the masquerade. The masquerade is the masquerade, the founder of this project. That is Leprosy Research Initiative. Representative will give us some words, because if they didn't provide resources, we will not be celebrating the success of this project. Can I call on Chrissa, please? The floor is yours.
Yes, thank you so much. Dear panelists, esteemed participants, and online audience, good afternoon from cloudy Amsterdam. My name is Chrissa Menexi, and it's a pleasure to be here today representing the Leprosy Research Initiative, or LRI for short. We thank you for the invitation to this dissemination events and look forward to learning more about the findings of this project funded by LRI. We are thrilled to follow its impact and the next steps forward towards lasting change. For those of you who are not familiar with the Leprosy Research Initiative, let me take this opportunity to briefly mention the core of our work. LRI is a collaborative venture aimed at boosting scientific research in leprosy and related diseases, founded in 2013 after years of declining funds for leprosy research and scattering funding. Our objectives are funding high-quality leprosy research through annual calls for proposals, strengthening research capacity in endemic countries, facilitating the translation of research results in policy and practice. As a leprosy funder, we are proud to have supported more than 85 projects worldwide on diagnostics, disability, operational research, stigma and discrimination, and transmission, together contributing to our vision of a world free from leprosy and its consequences. On behalf of LRI, I would like to commend the research team for their exemplary work on this project. After writing a successful proposal and starting the project in 2022, they implemented the project with scientific rigor and enthusiasm and received positive responses to their biannual progress reports. We are also pleased that the principal investigator, Dr. Ngozi Murphy-Okpala, has participated in 2 LRI workshops on data analysis and scientific writing, and the annual LRI spring meetings presenting her work, events which have further strengthened her research capacity. The project has already generated scientific publications which are crucial for disseminating research findings and achieving greater impact. In closing, we would like to congratulate the research team with a successful completed research project. Thank you once again for the invitation and wish everyone a fruitful event. Thank you.
Thank you, Krista, for your words of kindness. And we are glad that LRI is the second project LRI had funded for Red 8 Nigeria, GLRA, and now Red 8 Nigeria. So we're grateful. Next year we'll be coming again with some other proposals so that we continue the journey. Thank you very much. Yes, so Chinwe, can we have the agenda again so that we can quickly scroll through them so that we see what we have? Yes, so just scroll. Let's scroll down so that we see what we have. And so we have such different sections. We have taken the first part. Second part, we'll be talking about the case study overview. That will be taken by the principal investigator, Dr. Ngozi Murphy-Okpala, who has tirelessly worked on this project with the LTR counterpart. Then following that, we're going to have the first team, which is talking about understanding disease-related stigma. And that will be taking, first one will be a keynote speaker. That is Dr. Joseph Chukwu. Dr. Joseph Chukwu, you know, is a veteran of leprosy control. I can tell you that as far back as 1992, he started his work as a leprosy doctor up to today. So he's giving us some experience, you know, has gathered over these years regarding leprosy. And that'll be followed by a case study from this study, this particular research, which will be taken by Dr. Tahil. That will be followed by Team 2, where we'll be talking about participatory approaches in designing health interventions. And this will be taken by keynote speaker 1, Caroline Nunech. Caroline Nunech is from DHW, Wolfsburg, Germany. And she's the MIE officer there. She was very she participated effectively in the design, this co-design of the health intervention. So she'll be giving us a perspective on that. That will be followed by a case study, you know, by Ngozi Murphy-Okpala, the principal investigator. That is, will be the participatory co-creation and all that. Then that will be followed by impact of the participatory approach. She'll be telling us more on that. You know, the speakers will be telling us more on that. Keynote speaker here will be a person affected or persons affected. They are not here in person. They are going to be showing the video recorded before and after the intervention. And then that will be followed by another case study session, which will last for about 20 minutes, to be presented by Chinwe Eze, Director of Monitoring, Evaluation, Accountability, and Learning. And I should be speaking on impact of participatory co-creation on self-stigma or self-esteem. And that will take us to the fourth session, you know, where we're going to have panel discussions and all that. The question and answer will follow, and we'll wrap up after taking a virtual group photograph. So we're now going into the main meat of the webinar, where we'll be calling on Dr. Murphy-Okpala to tell us about the overview of the research. Over. Dr. Murphy, you have the floor. Overview of the project.
Thank you very much. Thank you so much. Thank you very much, sir. Good afternoon, sirs. Good afternoon, everyone. My name is Ngozi Mofiopala, and I'm a program manager here in Reddit, Nigeria. It's my pleasure to be here to give this presentation. I'm standing on existing protocol, acknowledging all of the dignitaries, starting from the Director of Public Health, Federal Ministry of Nigeria. Thank you so much for making out the time, and the Deputy Director, Dr. Chuko, on behalf of the National Program Coordinator, and of course, LRI here as well, because like as we rightly pointed out, this project wouldn't have been possible without the gracious funding of LRI. So we really appreciate the funding, and beyond the funding, the support in many other ways, capacity building and all of that. So thank you so much. While the screen is coming up, I'm just also going to quickly acknowledge very, very importantly, our colleagues, LTR, who we did this project alongside with. The project was actually a mirror image of the north and south of Nigeria to capture the different aspects of the national program, which we thought was very crucial, so that by the time this is whatever evidence being generated needs to be adopted, it will be quite representative. So okay, so in a minute, slides will be coming up, and I'm going to give a very quick overview on the project. And basically, we titled it Innovative Approaches to Health Education and Stigma Reduction, and we are using this project as a case study. So I'm hoping you can see my screen by now. Okay, or maybe not. Okay, so 1 second, I'm going to put that up again. Apologies for that. Yeah. All right, some of these things are technology. Anyway, so I'm hoping you can see my screen by now, though.
Yes.
Yes.
Okay, awesome. Thank you so much. All right, so I'm just going to do a quick overview of the case study, what the project is about, and I'm going to run through following this content, what is about the problem we try to address, how we went about it, and the effects which the rest of these sections is going to talk about. So this project was funded as a research titled Participatory Development of Audio-Delivered Interventions and Written Material and Assessments of their impact on perception and knowledge of attitudes towards leprosy. It's a cluster randomized trial that was done here in Nigeria, and acknowledging all the different partners from Leprosy and TB Relief Initiative Nigeria, NLR International, and DOR, German Leprosy and TB Relief Association, Germany. So it was a 2-year-long project, actually with an additional 5 months no-cost extension. And what is it we try to address? So very simply, the problem we try to address, I think already from the title, as the title suggests, is stigma, and we realize stigma has 2 components to it. So stigma towards leprosy and persons affected by leprosy, both perceived and that's actually enacted. And we try to address 2 aspects of the 2 key stakeholders here. So from the community members in terms of their perception about leprosy and how it translates to, everyday activities or aspects of life, from social participation, and how it impacts actually relating with persons affected by leprosy and associating with maybe either them or their family members, based on whatever reasons. We have a full section that's going to speak to explaining a little bit more about stigma-related diseases. I won't go further on that. But then on the other aspects too, which many of us may not realize, and I think that's components that we are going to dwell more on this afternoon, is for persons affected, because to us, they are the primary stakeholders to begin with. And what we may or may not realize is that when their perceptions of stigma from, for different reasons, primarily from people's reactions in terms of community members, how people respond to them, it has a way of actually affecting their own perception about themselves. So there are 2 components we try to study. We try to really focus on in this research, which is internalized stigma and self-esteem. And then one thing we also know for a fact is that when there are visible impairments, whatever level of disability associated with it, then it ends up exacerbating stigma and discrimination and so. And so for us to actually address, and actually go towards zero leprosy, the stigma and discrimination, we actually have to have a very intentional approach towards behavioral change. And then incidentally, as most of us, the audience here will be fully aware of, leprosy being an NCD actually affects, the bottom pyramid mostly in the society. And that is something that is common among that cadre. It's the low literacy level, especially in leprosy endemic settings. So what we try to do is we are trying to assess, written health education materials as we traditionally do most of the time, versus targeted audio delivered interventions. Could there possibly be a difference, in terms of how people actually respond, both individuals who are affected and primarily on community members? And then, so the research question that we try to address, we've crystallized all of this problem into very specific research questions. One being to investigate the perception of community members towards leprosy and persons affected by leprosy. Two, to investigate whether there's any difference in the impact on perception between participants who receive the audio and versus those who receive the written materials. And then three, which is assessing the impact of participatory development or co-creation of these health education materials on empowering persons affected in respect to their internalized stigma or self-esteem. So the rest of our discussion today is going to focus on the first and the third part of these two problems that we're trying to address. Okay, so the first step, to actually go about this is you want to, first of all, really understand exactly what the problem is within this context. Like I said earlier, this study was done as a mirror image, both in the North and South Nigeria. Exactly the same study was ongoing at the same time. So the first step is to actually contextualize what does stigma actually mean? What does it look like at the community level? And we did this by conducting a baseline evaluation to actually understand community members, what they actually think, what they know about leprosy. So this was done through a house-to-house survey. We had surveyed over about 770 people was our minimum size. We hit about 800 and over 800. The details will come in a bit. And these respondents were randomly selected. We had to use validated questionnaires so that whatever findings we get would be very valid, and there are things that we'll be able to share and will actually be comparable across regions. So having done that, we then had to move on to the next step, which was to comprehensively analyze this data. We did both qualitative and quantitative data. More on that will come up in a bit. And so we were able to put this into very simple, really break it down, using infographics and animations to actually explain what does this mean, at the community level. And so having done this, what we then did was, alongside persons affected by leprosy, and we had a total of 20 persons censored in each region, we then collaborated to co-create the development of these health education intervention materials. So it wasn't us sitting down to come up with what we think, but based on the contextual evidence that's been generated in the baseline survey, putting that together, showing it to, sharing that result, and then working alongside with these people, also alongside with community members, a few people from the community who are going to be the end users, of this product at the end of the day. And then, of course, with adequate representation of the national and the state level program staff, all of this. If you look at this picture, for instance, I think you can only point out one person here who was a staff from Reading, Nigeria, and then there was another picture somewhere with another person. So the point is that all of this was actually being guided. We as researchers were here as facilitators. So the content was being developed by these people, use of local language. In the South, we used Nigerian Pidgin language, while up north, the study was done in the Hausa language. And so based on all of the things that we put together, raised the draft, gave concrete feedbacks, and we had to go and design what was done, did a pilot, field tested it, and then generated concrete feedback, had series of iterations, and then finally came up with a final product that was tested. So these are just some shots of what it looks like. So having done that, having generated, co-creatively done the co-creation to generate the health intervention materials, we then proceeded to go to the community to actually then implement this intervention. And going back to the same people that we had talked to at the baseline, so the same respondents, same study tools, like I mentioned earlier, there were standardized study tools that we used. There's going to be a lot more on that later, so I'm just trying to give an overview. But ultimately, this is what it looked like when we went out to actually distribute this intervention material. So one arm of the study group received, I mentioned earlier, it was a 3-arm randomized control trial. So what that means is we had one arm that received the audio intervention, another arm received the written, and then we had a control LGA. And that's exactly what it was up north and north and at the south. So here's what it looks like.
And even get cure, it not be killer disease. Now bacteria will be with different one person snakes. And they person. But let me tell you, you could go stay long time around the person before you feel catch up, no because witchcraft, bad blood, or even unclean environments they possible. You know fit get up, don't touch your body, sharing of items, handshake, eating, or sleeping together. Even mama no dey give her to begin. No be because you do bad thing, go make you get leprosy.
So that just give you an idea. We'll have a whole lot of that further down later as we go. But in the interest of time, I'm just going to stop there. So some of the things that we've generated so far from this project. First of all, like we just heard now, that was just a small 30-second clip. So we have been able to generate, evidence-based contextual health education materials, targeting specific areas where we identified from the baseline survey what the issues are, what people are actually afraid of, the things that are triggering, stigma-related response in the communities, and we're able to create that material both in the audio and the written versions. They are freely available and can be used for campaigns in other areas. We've been able to generate this audio version is also freely available. Is going to be made freely available on Audiopedia. Audiopedia is a platform for disseminating health-related audio messages. Through this study, we did a cross-cultural validation of the 4 instruments that we used for the study, translated them both to Hausa language and Nigerian Pidgin, because there are 2 languages that we used for the study. And then we created a free XML version of the study. What that means is that the study tools that we use, we hope to share it more widely with InfoLab or InfoNTD platforms, which were recently rebranded, so that other researchers in other parts of Nigeria, could actually use the same materials and would have to go through the same process because we've done that part of the work for them already. So the rest of the study, the outcomes from this study, we're going to learn about in the rest of this webinar. Okay, so we've had a few publications as part of the products that have come out of this project, and also for disseminating as means to disseminate our research as well. The first is the study protocol that was published earlier in the year. Leprosy review, where the manuals and the manuscripts I was just talking about now, we have 4 manuscripts that have been submitted there. And then most recently, sometime in August, this came out, which was documenting the baseline study that I just referred. So this has been a long journey, 2 years plus now, 2 years and 5 months to be precise, starting from, July when the project officially kicked off. So these are all the phases we've been through. And then finally, it's really a pleasure and a privilege to be at this point where we are sharing the results with the rest of the audience. So in conclusion, one thing that has come out really strong and clearly is the fact that, if we are actively going towards zero stigma and discrimination, as indeed we are trying to achieve in Nigeria, particularly in leprosy endemic settings, it's very important to have targeted cultural specific and community-based health promotion interventions that actually address, identify determinants and can actually drive true behavioral change, if we're going to change this narrative in our society. And this is really crucial because if these are leprosy endemic areas where we are having, the kind of results or findings that we are showing, then we have to get to work to actually make this work and to change the scenario. And another thing is that it's also important that maybe the medium, may just be as crucial as the message. So as I wrap up, I do want to end this presentation without acknowledging all of our research assistants, 12 of them in all, incredibly fantastic people. This research was fully community-based. We couldn't have done it successfully without the help of our fantastic research assistants. So finally, just acknowledging our funder and then all of the partners. Thank you so much. So Dr. Nwafo, over to you. Thank you.
Thank you so much, Dr. Murphy Okpala, for this setting the stage, because I call this setting the stage so that our all ears and eyes to get the main result from this study. Please, because of time, please keep your questions. Either you type them in the chat box or you write them down, so that during the question and answer session, we'll be able to come back to you, give you opportunity to ask your questions, and then answers will be provided by the various speakers. So we'll quickly go to the next item on our agenda, which is where we'll be looking at understanding disease-related stigma. And then we are going to call our first keynote speaker, that is Dr. Joseph Chukwu, who I earlier told you is a veteran in leprosy control activities. He's currently the regional health advisor for DHW West Africa. So he'll be telling us his experience working in leprosy over the years. And we're going to do that in 10 minutes. I know he's an orator, but I would like to plead that he keeps it brief and to the point. Over. Thank you, Dr. Chukwu. Welcome.
Yeah, Igwe. Good afternoon, Dr. Nwafo. Good afternoon, colleagues. Good afternoon, ladies and gentlemen. I would be remiss not to recognize the owners of the land here, Dr. Anyike, now Director of Public Health, but I like to call him the NC Emeritus. Once a national coordinator, always a national coordinator. And of course, who is acting. And ladies and gentlemen, I stand on existing protocol. I would like to thank the organizers for giving me this opportunity. For me, it's actually a privilege. The research has been done by very competent people. And in my role today, I have the, shall I say, the luxury of simply relying on anecdotes, just sharing some experience with you. I don't have to do all the academics and all that. This is already done by Dr. Murphy, Dr. Tahir, and the team. So many of you who know me would know that I spent many years at Ozuakode, the leprosy hospital. And so most of what I'll be sharing with you today actually date back to those days. We cannot but start with the concept. I'm not going to give you any epistemological meanings of stigma here, but let's take this as working definitions. That for the purpose of the subject we have before us, we can say that stigma is about endorsing negative stereotypes or prejudicial ideas about others. So because of time, I'm going to take some of the things I have in the letter slides and bring them up here. It's essentially about a complex issue involving multiple areas: medicine, sociology, psychology. But it worries us because it undermines health by preventing access to critical health promoting resources such as healthcare and employment. And very importantly, ladies and gentlemen, it robs people, human beings, of their dignity. Every human being has innate dignity. In fact, our able chief of the African Development Bank, our own Professor Adewumi Adesina, once said that he was asked about development. Instead of making a very technical definition, he said development is about human dignity. I can't agree more. It's about human dignity. But what does stigma do? It often robs people of their dignity. If you go back to the other side, Chinwe, I won't be long there. Okay, or you can take it here. I just wanted to say that if you look at that cycle there, from the inner, this is about negative attitudes, it's about stereotypes we mentioned, it's about labeling, and all these have spin-offs. It affects the people, then the person affected begins to have a sense of shame, feels discouraged, and has a fear of getting help. And this can lead to a loss of job or home. It can lead to isolation and actually loss of relationships. So you can go to the next slide. Next slide, please. Yeah, so we know that this stigma actually thrives on myths. Often stigma is as a result of fear and or ignorance. So it thrives on myths. Let's take a few myths here and then report them immediately. Myth number one, for instance, that leprosy is caused by a curse from the gods or because of past sins. This is a myth. It's untrue. What is true is that leprosy is actually caused by a germ, or as we know since 2008, by two germs, Mycobacterium leprae and Mycobacterium tuberculosis, Mycobacterium lepromatosis. So we have those two organisms that are now known to be the causative agents. Again, there's a myth that leprosy has no cure. We know it is not true. Leprosy can be cured by people taking antibiotics. With our MDT, we can actually cure leprosy. Leprosy makes fingers to fall off. We know this is not true. And we know that these things happen as a result of the nerves being affected and recurrent wounds. So quickly, let's go to the next slide. Next slide. So I will just take some of these personal encounters. And I put in the first one there to show you that I think we should always start with ourselves. Can I, Joseph Chukwu, be guilty of stigmatizing? The short answer, unfortunately, is yes. And that's why I want to share that first one with you. When I arrived at Oswakole, a European trained doctor coming from the University of Vienna with all that. And I thought I was ready. I was exposed and I knew it all. But when we attended Mass on Sundays, as a Catholic I was, at a stage during the Mass, the priest invites the parishioners to exchange signs of peace. So you go and shake people or even hug them. But do you know what I did? Because I was stigmatizing persons affected who were also in the same church. I would go to one corner where there are only nurses and doctors to ensure that there is no person affected very close to me that I would then be tempted to go and shake their hand. I mean, I say this now, but I'm ashamed of myself. But I think it's a good way to start, to say that we can actually be victims to this also. So this is why I say it's a sign of peace. Even in the church, I was stigmatizing people. I was listening to the homily, but I was not walking the talk. The second one there is also about the priest and his cook. This was, I had just diagnosed leprosy in a man who happened to be the cook for a reverend father who was also a professor at the university. Barely an hour later, this priest who knew my a senior brother who was also a priest, came driving furiously into my office and was saying, I will speak a little Igbo now and I will translate. Joan Wanamo, Joan Wanamo, Joan Wanamo. What was he saying? He said, Joe, I'm dead. I'm about to die. So I said, Father, what is wrong? Please sit down. It turned out that the cook had just told him that he had just been diagnosed with leprosy and we gave him medicine. So you can imagine this professor and the priest of God now was worried about his life, about himself getting leprosy. I had to sit him down and quiet him and say, and reassure him that he's not going to die and nothing will happen to him. However, and I'm not going to forget this, at the end, I told him, if I ever hear that that man is sacked or he suffers any penalty because of simply being diagnosed with leprosy, which is curable, that I would not spare him. I would actually call him out in public. So I think he believed me and then did what he so. So again, let me take that third one. And I know we don't have too much time, but the Aba businessman and his mother's head. This young man was treated at Oswagode, actually of tuberculosis, because we had a combined TB and leprosy center. When he got well, he came back, but his mother was also with us as a leprosy patient. Unfortunately, this poor lady had some other complications, comorbidities, and died. And this young man came to me pleading, really crying. He wanted me to sever the head, actually to decapitate this lady's body, so that he could wrap this head and take home and bury it close to his house, so that he can actually feel the warmth that his mother is buried. The reason he was doing that is that because the people at home, the community, will not allow him to bring the whole body home because, quote unquote, this was a leper. So you see how much stigma and discrimination can go. In life and in death, these people were rejected. And of course, we refused. We got him to say, you either take the whole body or you just pray with us here and we will inter this woman there to Zwagada. And the latter we did. We buried her with full dignity because she's a human being. So we can go on and on, but I think we can, let's move to the right one so that we finish quickly. The hidden mother of the bride. You know how joyous an occasion it is when mothers, or indeed parents, but especially mothers, give out their children to in marriage. What happened here? This woman had leprosy and also visible impairments. And the husband came from outside the state, let's say from Benue State, and the bride is from, let's say, Ebonyi State. And they wanted to make sure that the people from Benue State, including the groom, do not see that the mother of this bride had leprosy. Otherwise, the marriage would be called off. So a compromise was reached. Another woman who did not have leprosy would stand in this person's state as the mother of the bride. While the real mother of the bride was in a room, locked away somewhere, crying. But she wanted to do the best for her child, as mothers always sacrifice. She was crying because she would like to be a full participant. But no, because she had been devalued by leprosy, because society would not accept that. She was crying in a room when the rest of people outside were jubilating. That is what stigma and discrimination can do. I direct the two, I can run across now, but I just want to mention the last two, the penalty one and that one, that we went to a place to hold a workshop, and it's owned by nuns. They took the money and we arranged to come to the workshop. But when they found out that leprosy patients affected were going to be part of that workshop, they returned our deposit and asked us not to come back there. So even those nuns were guilty. And finally, in the town, in Oswakole, that leprosy hospital where I worked, as you come into the compound, upstream, so to say, was a general hospital. In other words, for clean people. As you come down, it was the leprosy hospital where I worked, and we were referred to as Ndidao. In other words, the people downstream. And down meant really, literally and metaphorically, the persons affected by leprosy. So, ladies and gentlemen, let's go to the next slide. I just shared this as some of the experiences, but I think it's important to close on this note that it is not the problem that would defeat us. As long as, no matter what it is, with the right will and with the right determination, we can overcome this. And that's why we want to close with what we can do to combat stigma. We always start with ourselves. Educate yourself. Arm yourself with the knowledge. You listen to webinars like this so that you can separate myths from the truth. So you educate yourself, be aware of your attitudes and behavior, choose your words carefully. Don't call others garbage. Some of you have been listening to the news, you will see what is happening in the statistics, where people who are on the other side are being called garbage because they happen to hold different views. Don't devalue them. Educate others. This is important. Challenge disinformation and misinformation. Wherever you are, if somebody is saying leprosy is that, and you know it is not true, please be courteous, but don't fail to rebut that. That is a responsibility all of us have. Focus on the positive. Be aware of the danger of a single story. I think this TED Talk, a famous TED Talk by Chimamanda Ngozi Adichie. She called the danger of a single story, essentially saying somebody walks in there and he tells you that the people from a particular area are this way. And then you buy it. Somebody generalizes, and then you buy it. She's saying, beware, that's a single story. The real story is more complex. So don't just take that strand. Get to know more about that person before you can make up your mind. Support people, help restore their agency. All right? Remember, when you make people believe in themselves, they're able to do things for themselves. That is their agency. We all have agency. And include everyone. I think on that note, ladies and gentlemen, I think we can all agree that yes, there's stigma, and the research here that has just been completed, for which we're here to disseminate it, is also helping us to know what we can do. But at the end of the day, every one of us has to lead by example. And we must believe that if we work together, if we act together, yes, we can defeat stigma and get leprosy under wraps. Thank you very much.
Thank you very much, Dr. Chukwu, the veteran. Stigma is a big issue, especially for persons affected by leprosy. And as I said, it robs somebody of his dignity or her dignity. And so to combat that, educate yourself and respect people's agency and include everyone. Inclusion is the word these days. We need to include every person. Every person has a right to exist. Nobody made himself or herself, to have leprosy or some other conditions that are highly stigmatized. So in everything, they have the right to participate in community life, have the right to access to education and health and all that. So thank you very much for sharing the insights. For our audience, please don't worry, we're going to be sharing the recordings of this webinar, where we get further details of some of the things that are being said. Thank you very much once more, Dr. Chukwu. we are going to the next topic, which is a case study, of this research, where we'll be inviting Dr. Tahir to take on the next presentation, which is investigation of community knowledge, attitudes, and stigma towards leprosy in Nigeria. So the mixed method study. So Dr. Tahir, you have the floor, please.
Thank you very much, Mr. Chairman. Other protocols observed. I will briefly run through the findings of the baseline as a requirement for the interventions that were carried out in Taraba and Jaling and Cross River states. I start with this quote from Mother Teresa. The biggest, please go ahead. The biggest disease today is not leprosy or TB, but rather the feeling of being unwanted. Go to the next slide. Next slide, please. These are the talking points. We'll run through a summarized article that has been published in the Transaction for Tropical Medicine and Hygiene. Now, as a form of introduction, we have little evidence on community knowledge, attitude, and stigma towards leprosy in endemic settings, especially in our setting in Nigeria. And for us to embark on this adventure of addressing these variables, the study was aimed at finding evidence or to evaluate the community knowledge, attitude, and stigma towards leprosy in Nigeria. It was a mixed method study, which was cross-sectional in nature, that kind of surveyed community members as well as persons affected, age 18 years and above, living in the study sites. Next slide. Next slide, please. I said earlier, it was a mixed method study. In a mixed method study, you can have quantitative and qualitative combined, the so-called concurrent one, or you have quantitative, thereafter you carry out qualitative, the so-called sequential design. In our own case, the quantitative component comprised of questionnaires that were used, knowledge questionnaire, then some validated EMIC community stigma scales. EMIC stands for explanatory model interview catalog or community stigma, and also social distance scales. In the qualitative component, we have focus group discussions and key informant interviews in the respective study sites, which were Taraba and Cross Rivers, that was conducted between January and May 2023. Next slide. The results. We had a total of 811 respondents that participated, as opposed to the 770 that was required for the quantitative sample size. 420 were from Cross River, while 391 were respondents from Taraba states. The mean age was 37.8, with 42.5% of them being females. Next slide. Next slide, please. They were mostly married, or 63.9% of them. They have at least 6 years of formal education, 88.5%, and 72.9% were self-employed, while 71% were from the rural areas. 9.58% of them earn at least below 30,000 naira per month. By then conversion, it was around $60 per month, which is far low now. Now, looking at the knowledge component, the study found out that 49.4% of the respondents had poor knowledge of leprosy. And the poor knowledge cause across knowing skin patch as a sign of leprosy, only 39% of the respondents knew that. Also, skin loss of sensation as a sign of leprosy, 19.9%. Also, knowing the causative agents of leprosy, 32.9%, while 32.2% of the respondents will tell correctly mode of transmission. With these low gaps, then what are the responsible factors for the other missing numbers? We will see in the qualitative component, because some of the respondents mentioned a lot of things ranging from sexually transmitted, from eating together, and so on and so forth. In the study, we found out that good knowledge of leprosy was associated with advanced age, also higher educational level, and being from the urban centers. Next slide. Now, when we look at attitude and stigma, we measure the attitude, stigma and attitude from 2 points. We look at the community aspect as well as the individual aspect. From the community aspect, we use the EMIC community stigma scale, which is a scale that is validated and it ranges from 0 to 30. The lower the score, the better the stigma level. The higher the score, the worse is the stigma level. For the EMIC community stigma scale, I think the cutoff point is 8. Below 8 is acceptable, above 8 is not. Now, in our study, the mean EMIC score was 18.96. While for Cross River, it was 18.84, Taraba 19.8. There was no significant difference between the two states. Looking at the social distance scale, the social distance scales measures the distances an individual will be from a person affected by the particular stigmatized condition. In this respect, leprosy. While the EMIC scale is looking at community level or the public level, the social distance looking at the individual level. The overall mean score for the EMIC was 9.3, that's the mean score, plus or minus 7.03 as standard deviation. While for Cross River, it was 12.93 and Taraba 6.59. So there was significant difference between the two states. We also found good attitude towards leprosy patients associated with higher knowledge of the disease, being from rural areas, and also having higher household income. Next slide. From the qualitative components, one of the FGD group members described that disease, leprosy, is in the blood, and it is also inherited from parents and great-grandparents. So it is easily transmissible when someone in your lineage has the disease. Another quote, some people think leprosy is the work of a human devil, being charmed by another person. Some tribes believe that some tribes, can you go back to the last slide?
You go back to the last.
Huh? Anyway, another group said there is also a lot of stigma. This is from person affected. Please go back to the slide for the community, because we have two respondents talking differently. Some people think leprosy is the work of a human devil being charmed by another person. Okay. Then a male FGD community participants also responded. Some community members think that leprosy is a cause, a result of one's sins. People think anybody who is affected by this disease is a result of his sins. Then, for a female affected in the FGD group, there is also a lot of stigmatization from the community members because of this disease. I have a serious challenge with people in my business. People are not coming to buy from me, and they are running from me. Next slide. Next slide. If somebody hears that you have such a disease, that is leprosy, they will desert you. They will not go close to you, even in a group of your mates. Okay? As they will look down on you. Indeed, it is a sickness that drives you out of the people by a female affected person in a WD group. Next slide. Now, we also try to find sources of information about leprosy. In one of the KII by a community, a health care worker, she said, I was taught about leprosy in school. Then for a community leader, we read from the internet and we listened to radio programs on health talks, also posters pasted in hospitals like teaching hospitals or general hospitals. Next slide. Another respondent from an FGD group said women, they heard about leprosy in women's meeting and men's meeting using media like meetings to sensitize the public, reaching out to local community members through drums, approaching churches and clergy for information dissemination. Next slide. The discussion, I'll try to be very brief here. The study found that about 1/2 of the participants had poor knowledge of leprosy. These findings were similar to other findings from Nepal and India. It was also found that majority of the participants had negative attitudes that are driven by the perception that the disease is a cause, a result of previous sin, religious belief, and its infectiousness. This is also similar to findings reported from Cameroon, Ethiopia, and Nepal. Next. Now, the study also found that socio-demographic factors like age, gender, education, and residence were really determinants of poor knowledge of leprosy among community members, which is consistent with the findings from Cameroon, Ethiopia, and Nepal. Similarly, the study also indicated that mean stigma score of 18.9 ranging from 18.84 in Cross River to 19.06 in Taraba is higher than what was previously, higher than the cutoff point of 8 by the producer of the scale. However, these findings are congruent or similar with the earlier studies from Nepal, New Zealand, Nigeria, India, and Indonesia. The study also found that the mean social distance scale was 9.39. This is higher than the initial one reported of 7.67 from Nigeria, okay? But it's in agreement with what was reported from India and Indonesia. The study also discovered that age, education, knowledge of leprosy, residence, and households' incomes are determinants of stigma. And previous studies have reported similar findings. Go ahead. Next slide. In conclusion, we found there was poor knowledge of leprosy, poor attitude, and high stigma levels among community members driven by cultural beliefs and social and local concepts about leprosy. Socio-demographic factors were independent predictors of poor knowledge of leprosy and high stigma levels toward leprosy. Next. Culture-specific health education, that's conclusion. Culture-specific health education and behavioral change interventions are needed to address the identified gaps in order to address also the misconceptions, improve the attitude and lower stigma of community members towards leprosy, given the identified determinants. Priority. Thank you for your attention.
Thank you, Dr. Tahir, for this result you have presented to us. We see that it was worth it going into the study. So this was the result of the baseline, part of the research, which eventually we're going to do after the analysis of the post-intervention data. We'll see how whether there's any impact on the community knowledge about leprosy and all that and the attitude. Thank you very much. Please, audience, remember to keep your questions, whether you type in the chat box or you write it down, so that when we get to question and answer session, we'll be able to take your questions. Thank you. So we're moving on to the next. Item, our discussion, our next presentation, and that is Team 2, where we're talking about participatory approaches in designing health interventions for stigma reduction. And the keynote speaker, I hope she's around now, Caroline Gunech. Caroline, are you around?
I am around, live and
welcome.
here.
Thank you very much. And so we're going to be handing over to you to to tell us about designing / implementing co-creation of activities. So please, the floor is yours. Thank you and welcome.
Thank you so much. So I have 10 minutes, right?
Yes, 10 minutes.
All right. Dear audience, I have also the honor to contribute to this great event by discussing a subject that is close to my heart, which is participatory approaches in designing health interventions for stigma reduction, particularly in the context of leprosy. Next slide, please. It is not just a theoretical concept, but a powerful movement towards inclusivity, empowerment, and most importantly, the reduction of stigma. Stigma in all of its forms remains one of the greatest barriers to achieving health equity. And in no context this is more apparent than with diseases like leprosy. I think we have already heard that also from our keynote speaker, Dr. Chukwu. Despite medical advances that make the condition easily treatable, the social and psychological burdens of leprosy continue to weigh heavily on those affected. Communities out of misunderstanding, deep-seated prejudices often marginalize individuals and foster a climate of fear and shame. At the same time, individuals affected by leprosy frequently internalize the stigma, leading to self-stigma, deeply entrenched feelings of shame, worthlessness, and isolation. Addressing stigma is not simply a matter of education. Although that is part of the solution, it requires a more profound shift even, one that embraces the very people impacted by leprosy and allows them to be part of the solution. So why does participatory approaches matter? Traditionally, health interventions often take a top-down approach, where health experts design programs for communities. While well-intentioned, these interventions sometimes miss the mark because they lack the insights, perspectives, and lived experiences of the very people they aim to serve. So how can we fully address stigma without involving those who have felt its most powerful effect? This is why participatory approaches come into play. By engaging those affected by leprosy as co-creators of health interventions, we move beyond simply working for communities to working with them. Co-creation empowers individuals, giving them agency to shape their own narratives and transform their roles from passive recipients of aid to active agents of change. Next slide. When persons affected by leprosy are invited into the process of designing health interventions, several important things happen. First, voice and visibility. Co-creation ensures that the voices of those affected are not just heard, but are central to the process. Persons affected by leprosy know better than anyone the nuances of their daily experiences. that myths that fuel stigma, and the most effective ways to challenge those misconceptions. By including their voices, we also give persons affected by leprosy visibility in a society where they are too often marginalized or ignored. Second important part, empowerment. Engaging persons affected by leprosy in co-creation builds their confidence and self-esteem. As they contribute ideas and see their inputs implemented, they reclaim their dignity and worth. This empowerment is particularly important in tackling self-stigma, as it allows individuals to see themselves not as victims of a disease, but as active, valued members of their own community who can even lead change. Third component, cultural relevance. Every community is different, with its own traditions, beliefs, and social structures. By co-creating health interventions, we ensure that the interventions are tailored to local realities. This increases the likelihood of the intervention's success, and is designed up from the ground to resonate with the community's culture, values, and language. And last but not least, sustainability. When people are involved in the creation of a solution, they are more invested in its success. Co-created interventions are more likely to be sustainable in the long term because they are owned by the community and not imposed upon them by outsiders. So let me share some practical steps that we can take to participatory and co-creation. First, build trust and relationship. Before any co-creation can occur, we must first foster trust with the individuals and communities we aim to work with. This means approaching them with humility, openness, and respect, acknowledging past wrongs and making a genuine commitment to listen and learn. Without trust, there can be no true collaboration. Facilitate a safe space for dialogue. The process of co-creation requires spaces where individuals feel safe to express their ideas, share their stories, and challenge existing norms. It's especially important when addressing self-stigma. Acknowledging and discussing internalized stigma can be painful, but it's also a crucial step in the healing process. Workshops, focus groups, or community forums can serve as a platform for this dialogue. Ensure equal power dynamics. True co-creation requires an equal distribution of power. Persons affected by leprosy should not just be consulted, they should be given decision-making authority. This means breaking down hierarchical structures that might exist between health experts, NGO workers, and affected individuals. Every voice at the table should carry equal weight. The use of creative and participatory methods. Participatory approaches can include a wide range of creative methods. Role-playing, storytelling, and participatory video are just a few examples on how we can engage individuals in designing health messages and interventions. These methods are not only empowering, but also allow for a deeper, more personal understanding of stigma and its effects. And lastly, continuous feedback and iteration. Co-creation is not just a one-time event. It is an ongoing process. As we implement interventions, we must continuously gather feedbacks from participants, adapting, improving, and so on, so that it really reinforces the idea that they are partners in the journey and not just beneficiaries. These were the steps in theory, but let me also highlight how it turns out into practice, not only in Nigeria, but also from other global initiatives in the leprosy sector. Today I want to highlight an existing and powerful tool we've been using in our work in India, participatory video. This is more than just a filmmaking technique. It's a transformative process where communities come together to create their own films based on their unique ideas, stories, and perspectives on what truly matters to them. PV gives marginalized groups the opportunity to represent themselves, to tell their own stories in their own way. What makes PV so powerful is its visual nature. It doesn't just convey information. This is particularly important in communities affected by leprosy, where stigma can silence individuals, but it really amplifies voices that are too often unheard. PV has the potential to educate, influence, and advocate. However, despite its success in various social contexts, there is still little experience and also evidence in using PV to reduce stigma in leprosy. That's why we implemented a study in India to explore the impact of engaging people affected by leprosy in storytelling through PV. We investigated, or are in the process of investigating, how this process not only influences mental well-being, but also helps in reducing societal stigma and internal stigma. Our hope is that through PV, individuals affected by leprosy will reclaim their narratives, challenge misconceptions, and ultimately drive the changes needed to combat stigma. One story at a time, so to say. And for today, I want to share some visual insights how that turned out. Let us hear directly from my colleague and my dear friend, Dr. Shrilika Penna. And now, let's start a movie. I'm unsure, but I don't hear something.
Audio is not there.
Is there technical support? Otherwise, I'll try to share my screen.
Yeah.
However, it does not permit me to share my sound. There is not the option enabled to share sound.
A lot of stigma in India right now towards leprosy. There are a lot of beliefs that leprosy is a curse or it's from a sin. Because of that, people are not seeking care in time. This becomes a vicious cycle. So our approach is that we want to empower and motivate persons affected to come out, step up, and tell their own stories of their success. जैसे समय से दवाई ले समय से दवाई खइबा तो फायदा हुई make them help us to bring in more awareness about the disease. ये एक माइक्रोबैक्टीरियम लेप्रोसी नामक जीवाणु के द्वारा फैलता है। कुष्ठ रोग किसी को मतलब कोई छुआछूत का रोग नहीं है।
Okay, seems
Internet. Can you
internet.
try sharing the video?
Yes, however, the option of sharing sound was not enabled. I'm not sure if you could give me and grant me the power to do so. Then I could share, but probably. Yeah, seems it does not work. But I hope you could already see some, well, get an impression about how it turns out. because people affected by leprosy not only recorded themselves the videos, they wrote the script, they decided how they want to be portrayed and what they said. And I really invite you to check out LRI India's YouTube channel and watch the movie yourself. There is even a longer version available if you reach out to us. On YouTube, you see the sneak preview, so to say. Last words, last reflection words, because I don't want to waste your time. But it's really, if we reflect on the participatory approaches, we can imagine a future where persons affected by leprosy are not longer stigmatized. A future where communities rally around them, where health interventions are created with empathy and understanding, and co-created. The future is not a distant dream, it's within our reach, and the key to achieving it lies, as I said, in co-creation. When we work together with persons affected by leprosy, we craft interventions that not only reduce stigma, but also transform lives. We build a society where every individual is valued, where stigma has no place, and where health is a shared journey of dignity, collaboration, and hope. With that, I close my keynote and hand over. Thank you.
Thank you, Caroline, for that keynote speech. They say nothing for us without us. So what we seem to be hearing is if you want to create any, whether it's health information, materials, you should ensure that those people who are affected will be part of the creation of those things, like has happened in this particular project. So we're going to go to the next case study session, which will be how Dr. Ngozi Murphy will be telling us how the persons affected by leprosy participated in the co-creation of the materials, both the audio and written material that we use in this research. So Dr. Murphy, over to you.
Okay, thank you very much, Dr. Ladies. I don't know if you can hear it.
Believes that leprosy is a curse or it's from a sin. Because that people are not seeking care in time. This becomes a vicious cycle. So our approach is that we want to empower and motivate persons affected to come out, step up, and tell their own stories of their success. जैसे समय से दवाई ले ली, समय से दवाई खाइबा तो फायदा हुई. Make them help us to bring in more awareness about the disease. ये एक माइक्रोबैक्टीरियम लेप्रोसी नामक जीवाणु के द्वारा फैलता है. कुष्ठ रोग किसी को मतलब कोई छुआछूत का रोग नहीं है.
All right, thank you. So Dr. Murphy, over to you.
Thank you very much, sir. Thank you, everyone. Once again, good afternoon, speakers, and thank you, Caroline, for the excellent presentation and just perfectly setting the stage for participatory research. So I'm going to very quickly go into some details of what we actually did here in our setting in this study. All right, so I'm going to be talking through the overlay components, exactly give you a background on, just a little bit of more light on participatory research, what it's about for the benefit of the rest of our audience. describe what we try to achieve, and then walk you through the framework that we use, the CSES QID methodology, and then what it eventually looks like. So just by way of giving a background, what exactly is participatory research? Okay, so we've probably heard about it in different forms or in different names it's been called. So keywords are things like participation, involvement, activation, empowerment, you know, by whatever version you've heard it. So in research, we'll probably be more conversant with public and patient involvement, PPI in research, or patient engagement, you know, and all of the likes of it. All of what we're just trying to say is that we've shifted from the point where you are conducting scientific research on a particular group of people, but you move to the point where it's not just about them or what you are trying to do, you know, but basically to do the research alongside with them, to conduct the research by this person. So it could be a niche group of people. Like here, we are focused on persons affected by leprosy. It could be the general public, you know, but you want to get suitable representation because, quite frankly, if you really think about it, it's not very logical to think you know more about an issue compared to who is actually experiencing it. As we say in Nigeria, it's he who wears the shoes that know exactly where it hurts, you know. So simply put, participatory research is about conducting research in direct collaboration with those affected by the issue being studied. So it's an active partnership, you know, so it's whatever the core stakeholder group is. So be general patients or carers, you know, or members of the public, like I said earlier. And really, it's quite interesting, and this a field that is gaining traction in recent science because, quite frankly, research really wasn't meant to be conducted only by researchers. It should be done alongside the core stakeholders that I've said. And the interesting thing is, if you really think through it, there's a schematic here that walks you through the different stages. So when it's at the point of trying to identify what the problem is, or, you know, deciding on the methodology or how exactly you're going to approach the design or the actual data collection or even analysis, you know, different members of the public or different affected persons can actually participate alongside each step of the way, whichever part of the research, they can actually be actively involved, and they should be involved, you know, and that's actually the whole idea of participatory research. So the public aren't just meant to be, you know, mere consumers of research, can actually be involved at any stage. And when we talk about participation in research, is actually also a spectrum, okay? Because you know, talking about involvement, you could there are different aspects to it. So, okay, so but really, you don't want to. There are variants of it where it could just be metokinism. Okay, let it just be that we actually carried people along, or let it be that you know, but that would be the lowest level of, and that's not something we'll encourage because it's not just about representation, it's actually about active participation, active involvement. Okay, so the spectrum goes through from, you know, basically just informing people, you know, that, okay, CEO, we are doing something in this place, to actual consultation where you are, okay, we're asking, what do you think? Asking the opinions, what are your thoughts? You know, so that is yet another level where you could step up, you know, from that and actually get them more involved, get them to actually collaborate. And then ultimately, you realize that, and I'm using this schematic here because there are different gradations through the spectrum of collaboration. Okay, but this spectrum I like a lot because the outer, you know, biggest, broadest sphere is empowerment, because just like we saw in the previous presenter said, you know, when people who are affected by an issue actually take active role and take ownership of being in the driver's seat of addressing the challenges related to their own matter, it's much more powerful. And for something like leprosy in particular, you know, with all of the bad reputation it's gained over the years, is a very classic place where we should actively encourage and push more participatory, you know, research, participatory co-creation. I'm trying to stay away from the word research because really, participatory co-creation, the research component of it is in terms of the measuring, you know, and being able to document what we found and all of that. But the key thing here is the empowerment, getting persons affected to take leading roles. So for this project in particular, what was the objective? What did we try to achieve? Two things, actually. So like I mentioned earlier when I was giving the overview, we worked with 20 persons affected by leprosy, and it was a participatory co-creation process. And the two things we were trying to achieve was, one, we wanted to generate targeted health education content. And as you see further down in my slides, we ended up doing exactly that. And content we generated was translated into audio and written health education materials, which was then disseminated in the community. And that's a different conversation. So the second part of what we did was to actually find a way of systematically measuring what was the effect of this participatory co-creation process. How did it impact on the persons, these 20 persons that worked with us? How did it impact on them? How did it impact on their self-esteem? How did it impact on their, whatever variants of internalized stigma that they may have acquired, in the course of having to live with leprosy over the years? So we did this also alongside with some community members, and then of course the national program. Per region, there were two facilitators who were the researchers just to facilitate this process. So this content was, proudly generated by these persons who we worked alongside with. So just to walk you through the methodology. So there's a framework called the 6SQID framework, right? Which simply means 6 steps for quality intervention development. And where this comes from is the fact that somehow in literature, if you look through scientific literature, there's a whole lot to talk about, assessing. In fact, the bulk of research is largely evaluating different interventions, public health interventions, whatever type, be it clinical or be it, behavioral change interventions. So, but there's a whole lot on that. But it turns out that there wasn't so much on actually teaching or demonstrating how you could reproduce generating quality evidence-based interventions. Okay, and so for something like leprosy, for instance, is a classic example because we've known, just like Dr. Chukwu right there pointed out to us earlier, we've known the cure for leprosy for a while, even though there are places where people do not know, but then beyond just the basic knowledge of it, how do you translate, in an area where is endemic, like leprosy endemic communities, where we intentionally chose for this particular study, for instance, how do you want to generate quality health education materials that will actually translate to behavioral change? So we use this SQID framework to try to achieve that. So just very quickly, I'll run through the 6 steps, which is 1, defining and understanding the problems and its cause. 2, you want to identify which causal or, which of the contextual factors you can actually do something about, which of them are modifiable, and which of them have the greatest scope for change. Who will actually benefit most from that if you actually alter something? Because really, by the time you start asking questions, you see that there's some things you may not be able to change. And the 3rd step is deciding on the mechanism of change. Then 4th, clarifying how this will be delivered. Number 5, testing and adapting the intervention. And finally, 6, collecting the sufficient evidence, of the effectiveness to proceed to for rigorous evaluation, which, like I said, when I was trying to give a background on this, somehow, oftentimes, we just jump to this number 6 steps. So, but it's important, this CCSQID framework met a huge gap, in the public health space by actually helping to generate a way to systematically, create quality health interventions. So, as proposed by Wright and his colleagues. So again, in as much as there are 6 steps, how these things can be. It's, some things are easier said than done, and some things that, stepwise things like this in real life are often not that linear. So in practice, it's actually quite iterative. Okay, so I'll just pick the steps one after the other and tell you exactly what we did. So in step 1, which is trying to define the problem and understand, contextually, what exactly does stigma mean? Fortunately for me, Dr. Tahil did an excellent work capturing what we did in the baseline study, because what we did was we went out to try to actually quantify what people in these respective communities, this highly endemic leprosy communities, you would easily almost think or assume that, since these are places where we've had leprosy for a long while, at the least people probably have an idea what's, is going on, what is leprosy. It's easier to be afraid of something you don't know about. So, but it was really interesting to see some of those findings, like he already shared very articulately earlier. So I won't go into all those details. So what we did was first of all, capture, try to quantify what do people in these communities know about leprosy? What do they really think about leprosy? You know, so there was a knowledge assessment, then there was the MXCSS, which was trying to assess, okay, so in terms of stigma now, how do they actually relate to people alongside with the social distance skill, just as the name implies? Okay, so how do people actually interpret, you know, being amongst persons affected by leprosy? So for instance, some of the questions that we're asking here were things like, if you know somebody has leprosy, for instance, will you want to rent your house to the person? Will you employ the person? Will you give the person a job? Will you allow your child to marry the person? So those are the simple practical questions, you know, that these tools actually document, and they've been rigorously used in different settings, you know, to show that they're actually measuring what they say that they actually measure. So after that, proceeded to actually identify associations, you know, based on further analysis, exactly what these things are, what are the predictors. Again, like I said, I want to run through all those details because Dr. Tahir has already captured that. And then finally identify some of the enablers, you know, and barriers. So, you know, so that first part of the job, the baseline data collection and all of that, was done by, you know, the core research team alongside with the research assistants in the field, who I had mentioned earlier. So translating to this group of persons that we had to work with, we had to break all of that down, you know, to simple infographics, you know, simple numbers, simple proportions. What does this mean? This is what people think, you know, and all of that. So that's how we're able to clearly define what the problem is in our locality, you know. So in Taraba State, in Cross River State, these are the two places where this project happened. So step 2 was then identifying which of the causal, you know, or these contextual factors now, which of them can we do something about? You know, which one can be changed? So it's really just a follow-up based on what we found in the baseline. Which of these identified factors are able to change? You know, are there those that we can modify? So having teased out all of those results in that simplified manner, we're able to say, okay, you know, so based on these things that we found, these are the things that we can actually modify. Then step 3 is then deciding on exactly what it is that we're going to do. So this is the point where they then started designing the health intervention materials. So what we had done, we created an SOP, a standard operating procedure, you know, in terms of a simple document based on this 6SQID methodology to help to frame, you know, based on the results. So for instance, like we have on this table, this is exactly what we used. So for each of the relevant topics, in describing leprosy, for instance, how is it transmitted? What causes it? What are the symptoms? What are the, you know, how easy is it to transmit it? And all of that. These are the questions that we're asking. So we pulled out, we're able to extract the results from the baseline analysis. And then these persons, you know, in this group of participatory co-creation, alongside with the other committee members and program staff, sat down together and in their own local dialects, in Hausa language, in Nigerian Pidgin English, then crafted suitable messages to address each of these specific things that we identified, you know, and so designed intentionally targeted messages to address these specific gaps that were identified. And then the next step, which is identifying how to deliver the change mechanism. So here for us, in this context now, for this research, this came down to 2 areas, 2 key things. In fact, 3, but I'll get to the third later. 2 key things were content design, designing the content, and actually how to deliver that content. So I'll take the first one, content design. So they were at liberty to decide how long should this message be, for instance, you know, what should the duration look like? What format, you know, should we just write it as text or should it actually be designed? You know, how will people actually, in our environment, how best do people actually assimilate health education materials or health or information generally in the first place, and then more specifically, information, health education materials, you know, and then what format should we use? Should it be how we spoke in terms of how should the narrator, for instance, for the audio content talk about it, or should it be dramatized? Should use a male or female voice? So these are all the things that they decided by themselves in this group, you know, and then of course, whatever kind of cultural nuances, as you understand, here's the way you phrase a sentence and you end up being offensive or communicate the wrong message and all of that. So these are some of the things that they had to put into consideration. And as I'm sure you can guess already, this didn't happen for 1 or 2 days. It did this over a 7-day long period, you know. So it was quite an intense co-creation process. And then for content delivery, how best should we actually administer these intervention materials? You know, people had their different thoughts and contributions and all of that. How often should these materials be administered? Should you just give it one time, or what frequency should we use? And all of that. What should the format be like? What kind of variants? You know, should we have multiple variants, maybe flyers, booklets, and all of that? So I'll show you a couple of pictures of what the final product looks like, but it was a result of all of these discussions that happened there and all of the ideas that they generated by themselves. Just worth mentioning too that we had to also create at the baseline, we did a communication needs assessment, which was very helpful to actually show how best people commonly use access information in the communities. So the next step, step 5, which is actually testing and adapting the intervention. So at this point, you would think that after putting all of these things together, it was it's really straightforward, you know, and out comes the cow for something like that. But really, it wasn't that straightforward, because by the time we were done, put all of the thoughts and crafted it, literally generated a TOR for whoever was going to do the design and the voiceover at the studio, produced the first draft, and we took it out to go and pilot test. Of course, you have to do pilot testing in a different, retest it in a different audience, not our study population. So we did that. Our research assistants went back to the field, identified a separate group of people, similar people, of course, and then the pilot tested it. And this happened over a period of 1 month. Now, we got to, help them to systematically record whatever the feedback, that they had. And we're looking out for comprehension. How appropriate was this material? How attractive was it? How were people engaging with it and all of that? So these are the different things that we actually sought out to articulate before we generated, mass produced the final version. And he came back with a whole lot of feedback, and it was interesting because you know how it is sometimes in the communication needs assessment, we had asked, and actually asked and even tested how well people could read, in Pidgin English and all of that. So by the time we had this final material out, one interesting thing, for instance, that happened for us down here in the South was a good number of people could read could not read in Nigerian Pidgin English. Of course, they could read in English. They talk Pidgin, right? But to read in Pidgin was a problem, right? And then in our audio arm, no issues whatsoever, because of course they are talking in Pidgin English, so everybody understood what they were saying. But for the written arm, it just didn't work. And so we had to reproduce every single item, now both in English and Pidgin English as well. So, and this was how we eventually, and of course, you had to do that in the audio arm, because being a research, you have to do exactly the same thing, so that there won't be any confounding factors. So that was what we did eventually, reviewed severally, and then finally produced the final version. And this is what's, okay, so, okay, and then finally, okay, so step 6, which is the next step, to collecting sufficient evidence of, how collecting the evidence of what you have. And for us in this project, this was achieved through a 6-month intervention, period, where we then distributed the materials that were generated in the communities. Okay, so again, it was the same people that we had interviewed at the baseline. So just to recap, for the benefit of, I'd mentioned this in passing in the overview. Well, this is a 3-arm cluster randomized trial. So one group of persons received audio materials. The second group of persons received written materials, exactly the same content. And then the third group of persons was the control group, did not receive any health education materials. So we just completed data collection for the community members just this month, at the end of this month now. So findings of the results for that stage is going to come out later. Just to give you a picture look of what it looks like when we're out in the field. So on the picture further down on my left is what the written health education material look like. Like I said earlier, there are different variants. So there's some flyers, some leaflets, and then eventually you had the jotter as well. And then on the top right corner was someone in the community just listening to the health education material. So those were solar-powered audio players. It's simple MP3 players. That's a simple slot and play, and then it plays. Another picture of somebody else with cooking outside, and then yeah. So I just love this picture. It really just, yeah. So anyways, so just the long and short, to conclude this presentation, just capture what we've been talking about. What I just tried to do was to give you a breakdown of how in this project, being the case study of this webinar, we actually applied this co-participatory co-creation process using the CSQID framework. Is an established framework, has been used severally, very well cited. So it's something that is replicable, it's something that can be done, it's something that we strongly encourage because, you know, participatory co-creation, it's really, it has a very empowering effect, and it's something we should strongly encourage, especially for highly stigmatized diseases like leprosy. So in this project, as I've just shown, we're able to successfully apply the principles of CSQID participatory approach to actually develop tangible outputs. So one was ready to use message content. Like I said, in the audio, same content was used as audio, same was used as written material. They gave the guidance and all of how they wanted the final products to be, you know, for the graphic designer and the voiceover artist, and including the potential distribution plan. Okay, so I have, okay, so maybe further down, okay, yeah. So I think further down in maybe the next presentation or so, we'll see more clips to save time. I didn't put them on this particular slide, but further down, maybe in the next session or so, you're going to see what the final output looks like. So on this note, I just want to say thank you very much for your rapt attention. Dr. Mafo, over to you. Thank you.
All right, thank you very much, Dr. Murphy Okpala, for this presentation. Again, it's still speaking to nothing for us without us. Always important and good to allow the persons affected to have meaningful participation, because like you said, he who wears the shoes knows where they pinch. So good to hear that they were fully participated in this design process of the health education materials to reduce stigma, both internally and community stigma of persons affected by leprosy. Thank you very much. So we're going to quickly move to next presentation. This is on impact of participatory approaches. You know, what impact has this had on the persons affected who participated in the co-creation of the materials. And as I've heard, you know, after 6 months, they had to go back to get their perspective. Now, what has happened? How has this given you voice? How has it, you know, reduced stigma, self-stigma, and all that? So we're going to, first of all, the third keynote speakers will be clips of persons affected by leprosy who were part of this co-creation. So please, can we have that? And immediately after that, we are going to call Ms. Chinweze to now tell us, yes, after the creation and all that, then when we went back, what did we find? You know, what was the impact of this co-creation of these persons affected who were part of the design? Over. So can we get the video, or is it audio?
Hello. Hello.
Hello, Peter.
Sorry, I'm Mr. Peter, and my battery is running down, so that is the reason why I'm interrupted. Sorry.
Okay.
I have yes, I have few concerns here that I want to hold out. One of it is well, a project like this, IDA just know about it a week ago, and I learned that today is the closure. Just saying that maybe next time we begin from the beginning, we know about it and then follow it up. That is one. And then second one is about the presentation from Dr. Joseph Chukwu. He made mention of stigma and discrimination about 3 places. Well, I want to say that a project like this, if they empower persons with lived experience, with knowledge, that they can now stand by themselves, defend their rights, know what is their right, and then stand by it. If not, the one that I will mention that he said someone that a woman whose son was getting married, and then they lock her in the room because he just want the son to have a wonderful celebration, and then she was crying in the house. Such avenue, some kill themselves. But if it happens that this woman have this knowledge, you know that no, it's his right, even though he's affected by leprosy, but she have right to celebrate like every other person who is not affected. She wouldn't have been in the house, and that would have raised that situation. So I am impressed with Rate 8 for bringing such program and then impacting meaningfully for persons affected. I am very sure that during this project, and even as it's come to an end now, it will help areas where this project have educated in order to reduce stigma and discrimination in those areas. I am calling on other partners, especially our Federal Ministry of Health. They should help us in order to, when preparing budgets, let some funds be allocated to such program like this, so that as we are working towards zero discrimination, zero disability, and all that of the global, let us do this, little by little. Maybe before we know it will be all over in the country, and stigma and discrimination will reduce. Thank you very much. And as my battery is getting low, maybe I will not be able to conclude today's session with you. Thank you, and may God bless you. Thank you.
All right, thank you, Peter. Thank you very much for intervening before your battery runs out completely. Yes, all your points are well taken. Also, by the way, those who don't know, Peter is the national president of IDEA in Nigeria, and is making sure that his community is not left behind. So all your points are noted. Thank you. You can still go on until your battery runs out. Okay, so Chinwe, sorry, the videos now, please. I think the network is not moving, and we can't hear a thing.
I'm a teacher. Good morning. My name is Achobeke, 49 years of age. I'm affected by leprosy. For what they are done, before I could not go out. People are talking so many things, but now I'm down with them. Since that time, I acquired the knowledge. Since that time, I am very, very okay. I can now tell people what that people should not run away from leprosy. People should not go about leprosy. Leprosy can cure. Leprosy have a drug. So I am very, very okay. The business I will not do before. Now I started doing my business. I'm a caterer. We need to do kitchen work, cooking, doing some guns for people. But now I am bound back to do my business. I'm very, very okay. I want to thank you so much. God bless you. Thank you very much. Yawa, wai na so ne zan tambaya ne dangane da wannan miki da aka kira gonan na cewa da muka yi kwanakin baya. To, ne kake ganin ya canza a gare ka sakamakon wannan miki da muka zo muka yi, sannan kuma daga koma zamantakewanka da iyali da kuma ainihin mutane da kake mu'amala da su. Ko kana gani akwai canji, akwai fahimta da ka fahimta kan wannan miki wanda ya sai ka ɗan canja wani fahimta ka. Gaskiya akwai fahimta sosai kuma akwai dangantaka tsakanina da mutane sosai don kwanan bayan da na kamu da wannan ciwo din gaskiya mutane suna kusa ne sosai ba ko mutum suna mu'amala tare da su ba amma da taimakon Allah da na je na samu jinya ai jinya na gaskiya na samu sauki na fara mu'amala da mutane kuma suna tambaya na yaya na yi har wannan ciwo din ya kare a cikina ina ga musu nake ga idan mun je an yi mu fita an ba mu magani mun ta kuma gaskiya abin ya yi mu sauki sosai kuma wannan shi dalilin da har na samu sauki ina mu'amala da mutane yari na kuma yanzu ba ta kuke ni kuma ba kuma ina ta tura mutane a inda ya kamata su je nemi wannan taimako a asibiti inda na samu sauki kuma kwanan baya a san cewa akuya ne in kaji akuya shi ne ke ga maka wannan damuwa to mun zo mun fahimta ba kadai akwai ba abubuwan da dama dai in ka kiyaye da samu to wannan ne mutane da ko an fito min da abinci kowa yana damana amma yanzu ba ka
explain how the business start because it don't say. But since I start to go down Calabar, I come back. I come to here. So before when I did with that leprosy sickness, nobody will come nearer to me when they get me. And I suffer because the way I sleep, I know the people outside. I know the people outside. I will stay inside my house. Think of that, as some people don't have to attend leprosy sickness. From there, they know the phone nearer to me. Even good my so I miss it. When I come back to Calabar, I come to the change of my life. Okay. From there, when people they do occasion, I will just come to door. But inside my body or my heart, it is change to me. So when I hear them, they will tell me to put that leprosy woman from out there. From there, I will stay. When I do tomorrow, I don't go back. Until I feel like that, they suffer that sickness. Okay? This last Calabar when we go here, coming back, I consider the change of different of my life for that leprosy sickness. From there, when people do a patient, I will go near that to them and they put together, they will talk together. They know they even put their body saying, that is leprosy woman. I will come near that to this place where we live. From there, like that, I will follow them, even my children's friends, then they continue to follow them. They know they talk about that leprosy sickness again. From that time till now, this year, me, so far, I walk, I do everything, I watch things, I think, I talk, everybody, all our compound, we follow together, we do, so now we do something like leprosy woman again. You understand?
Good morning. My name is Meribas Mabasi. How I see myself now, I get very sound, very good. Since I returned from that program, research program where we went from people, I was agitated. They know, I know they enter the midst of people. As I come go that program, come back, now my eyes come open. Now I get very free to work out with people like this. To do anything I want to do. My business, I dey carry on fine. Unlike before, I dey stay inside. If I don't receive the medicine, finish me. I stay inside. I don't go miss people. I know I should shake the people because I didn't say the kids think they want me. As I don't go there, don't get high there. My eyes don't open. Say, I know say I don't get free. Then I don't dey associate with people. I dey go around. I dey do my business. I dey do everything. I dey work with people. I dey enter everywhere. No problem. I don't get wahala with anybody. People dey see me to themselves, and I dey never go anywhere. I dey do everything I dey do. Everything do well.
will be very fine. And the people might be receiving fast. In some way, I compose. That is now around and you do up. Oh, I'm so proud of myself. I'm happy. I say no grace to red A. No grace to them. They do well. God will bless them and they will continue to excel. As in they work out, they help people. They do things so they make people happy. See now, as they work out well, when I can work in the midst of people, no problem. Unlike before, why then? Hide inside. I know people want to spaces. I don't want to. I don't enjoy the way they don't do well with me. Only God bless them. Mama Basi, good morning. Ah, my daughter, good morning. What you do like this? Now so I see now last week I wake up, see this yama for my body, wey dey lighter than my skin color. And I know they feel anything. You know they feel me self. Now if I can't go hospital, nurse can't look me finish, can't do test. She can't tell say na leprosy. Leprosy. Ah, Jesus. God forbid. Now where you get this disease from? How did she shift? Mama Basi, why now? Why they run now? Them don't give me medicine where they take.
Mama Basi, wetin happen? Why you dey shout like this morning?
My neighbor say she get leprosy.
Wait o, na because of leprosy you dey shout like say she keep person. Leprosy no dey catch like that na. You no fit catch am when you go close to person wey touch am or shake hand with am. Person no fit get am when they sleep together, chop from the same plate, or share anything together. E no even be by witchcraft, bad blood, and dem no fit born you with am. Na bacterial germ dey cause am, and na through air e dey spread when you dey near person wey dey sneeze or for a very long time. Sometimes e dey take years before e go comot from person body. My people, when you see any person wey get the same yamayama your neighbor get for body, and you go hospital, dem confirm say na leprosy. As far as the person begin to take im medicine well, e no go fit give am another person. E go get well, and im hand and feet no go join. We fit prevent the community from leprosy.
Oh, now so thank you, Jesus. I beg you, make I ask, this treatment how much should they pay for it?
Now that one sweet pass. Treatments are free, so no need to go to look for concussion. Open spiritual house or they avoid some kind of food. If person will get leprosy, take medicine well. People will say they tell her for hospital. Not just 6 to 12 months. It goes strong well again. So don't they run from people who get leprosy. They be human beings like you and me. If you see any sign for your body, like we don't talk so, you will call these numbers 081 6054 9949 081 6054 9949 or 080 7701 5058. Or make you visit the health center within here. Person who want this safe, make it come because safety don't come.
Yes, so now this safety we go dey preach. No more stigma, no more discrimination. I beg.
Direct Aid Nigeria and Cross River State Ministry of Health join us together. Bring good at this message. Let us know. It's well with people.
Sana'an nan don biyan bukatan kaina da na iyalina don bari da wani hanyar taimako sanda na kamu da cutar kuturta. Da kwastomomi na suka ga wasu lambobi da ke fitowa a cikina sai suka fara gaya wa mutane. Na rasa kwastomomi na har ya kai ga in na dafa burkutu ba mai tambaya balle a sai. Har baki ma suka daina saya a wajena. Cikin kalilar lokaci na rasa hanyar cin abinci don ba na iya sayar da burkutu. Karfina har mai gidana yana ce min shi baya sha'awar auren kuma ga 'yan anguwa sun kai labari ga wanda muke haya a gidansa ya zo ya zubar min da kaya a waje na fuskanci kiyayya sosai sai wani da ya fahimci me cutar kuturta ya zama abokina har ya aure ni don ya san ina shan magani bayan shekara 9 muna da 'ya'ya 3 kuma ba wanda ya kamu da cutar a cikinsu har mai gidana yanzu na warke burina ya cika kuma ina farin ciki sosai masu ɗauke da cutar kuturta ma mutane ne ba sa jin daɗi in mutane suna kyamar su ko su ci mutuncin su kada kuma ku daina sayayya a wajen su.
All right, so thank you. That was we've heard from the persons affected who were part of this and the impact the participation had on their self-stigma and all that. So please, we call on Ms. Chinweze to kindly present to us the impact of this participatory co-creation on self-stigma and internalized stigma among persons affected who were part of this study. Over.
Okay, good afternoon, everyone. Thank you, Dr. Wanford. Thank you, everybody present and in this webinar. It's good to have you around. It actually feels so good. Looking at those testimonies from our participants of the co-creation, it was really quite encouraging, and I feel good seeing them because I was with them in Calabar during the co-creation exercise. Some of them actually came in quite gloomy, feeling sad, but by the time we ended, it was actually a 7 days event. By the last day, a lot of them were singing. As you can see from the video, a lot of them, the songs you heard there were actually, let me say in quotes, produced by them, and they were very happy about that. So the task I have now is to present to us the impact of the participatory co-creation on these persons affected by leprosy, and the focus will be on their self-esteem and internalized stigma. Next slide, please. So by way of outline, we've heard a whole lot about internalized stigma, self-esteem, but I'm just going to say a little about it, not to belabor the topic. And then I'm going to talk about how we measured these concepts, these constructs, and I'm going to talk about the results, the quantitative results, and the qualitative results. And finally, I'm going to talk about the change mechanism. What is it about this participatory co-creation that we think that actually produced this result that we saw in these people? So, and when we talk about internalized stigma or self-stigma, just like every other speaker has said, we've talked a lot about stigma. Stigma can be a public stigma, it can be self-stigma. When we talk about public stigma, we are talking about stigma enacted by outsiders towards an individual. But when we talk about self-stigma or internalized stigma, this is a stigma that occurs when individuals internalize negative stereotypes, beliefs, or attitudes about themselves based on societal stigma. One thing we need to understand when it comes to stigma is that there are about 3 components, mechanisms of stigma. You have stereotypes, and when we talk about stereotypes, you're talking about some harmful and negative beliefs, usually fueled by poor knowledge or societal beliefs, cultural beliefs, myths that people actually have towards a group of people. And the other one, you talk about prejudice, and this is when you accept those harmful or negative beliefs, endorse them to be true. And then discrimination, your behavioral response to the prejudice. So in terms of leprosy, there are a whole lot of stereotypes, beliefs, negative beliefs concerning persons affected by leprosy. Some of them are that leprosy is a curse or is sort of a punishment from the gods, that leprosy is caused by witchcraft, that affected persons should not associate with others because leprosy is highly contagious. Leprosy is a hopeless disease. It is incurable. It is spiritual. You need to go to a traditional healer or you go to church to get prayed for if you actually want to get cured. And that persons are affected by leprosy should be isolated or ostracized from the community. So because of these negative stereotypes, beliefs, when a person affected by leprosy internalizes this, it affects them, builds up negative emotions within them. This affects their low, their self-esteem, making them to start seeing themselves not like every other person. For them, they now look at themselves as somebody that should not associate with every other person. This leads to social withdrawal, leads to unwillingness for them to pursue anything in life. And generally, it affects their mental well-being. It affects their quality of life. Next slide, please. So when we now talk about the relationship between internalized stigma and self-esteem, there's usually a negative correlation between self-esteem and internalized stigma. Usually when an individual internalizes stigma, it makes them to begin to view themselves in a negative light, which leads to decline in their self-worth and self-esteem. And when someone is already seeing himself in that, So when somebody is already feeling that way, this can reinforce, because it's just like a vicious cycle. It can reinforce the stigma and also make this person to even continue to feel very low of him or herself. And when these things combine together, it leads to poor mental health. And then this person feels bad. This person continues to ostracize himself, withdraw himself from the society, and wouldn't want to associate with any other person. Next slide, please. So I want to discuss how we tried to measure stigma and internalized stigma and self-esteem. So for the quantitative measures, we used 2 scales. We used the Rosenberg self-esteem scale, which is a 10-item scale ranging from, the responses ranges from strongly agree to strongly disagree. And for the scores, depending on the score, because by the time we finished, we collected the data, we summed up, depending on the responses, the person can have 0 or 1 or 2 or 3 or 4. By the time we finished with the data collection, we summed up the points each individual had. So the higher the score, the higher the level of the self-esteem the person has. That means the person has a high level of self-esteem. But for people that had lower score, that means the person has low self-esteem. For the internalized stigma of mental illness scale, which is actually, the tool was actually made for mental illness, but it was adapted for leprosy. For that particular scale, there is a 29-item scale, which also the responses ranges from strongly agree to strongly disagree. So the scores, depending on the total sum of the score, higher scores also indicate that this person has increased perceived stigma, but lower scores indicates that the person has low perceived stigma. For the qualitative study, we used focal group discussion guides, and the essence of the focal group discussion guide is for us to assess how stigma and self-esteem around leprosy has changed over the past 1 year. Because when we did this intervention at baseline, we did the baseline, the timeline, the baseline data collection was done in June 2023. So this focus group discussion, the qualitative data collection happened a year after. So we wanted to assess what is the impact of this participatory co-creation on stigma and self-esteem around leprosy for these persons that participated in this project. So this qualitative study was actually conducted at Endline, and some of those things that we heard them trying to discuss in the video. So for the timeline, we had the baseline data collection in June 2023, and then July 2023, we had the 7-day participatory co-creation workshop, which after 6 months, we had the first follow-up data collection. By the second month, by July 2024, the second follow-up data collection happened. And then after this data collection, analysis of the data and report writing. Next slide, please. So this is the result of the quantitative survey. So for the participants, the demographic statistics, the mean age of the participant. Meanwhile, I want to say that we started off with 20 respondents, 20 participants for the co-creation workshop. But however, unfortunately, we lost 2 of them along the line. So these people, the final group of people that we continued with, which is about 18 of them, their mean age was 46.1 years. Gender, the female components were about 56.6%. 83.3% of them, which translates to 15 in number, had formal education. 77.8% of them were married, which is 14 of the participants. Also, 14 of the participants were self-employed, 77.8%. Those that had multibacillary leprosy were 13, which is 72.7%. And those that had either grade 1 or grade 2 disability were 61.1%. Looking at the results, just like I said, we had a baseline, collected data at baseline, collected data at midline and endline. So for internalized stigma, just like I said, we used the ISME, the internalized stigma for mental illness scale, which was adapted for leprosy. So for internalized stigma, when we measured at baseline, the score was 68.29. And just like I explained before, it is a 4-point scale ranging from 0, the scores ranges from 0 to 4. So based on the score, by the time there are some of the questions that were negatively worded, so we had to do a reverse coding and before we did the sum of all the items. So those that have higher score shows that they have high perceived stigma, and lower score shows that they have low perceived stigma. So at baseline, you can notice that we had 68.29, which is quite high. Mean difference of 17.14. And at midline, the figures started dropping, and you can also see it in the graph below. It moved from 68.29 to 59.83, mean of 13.85. And at endline, we had 43.56 with a mean of 9.63. Now, for self-esteem, we started out with 17.78. Just to reiterate what I said about the tool, we used the Rosenberg self-esteem scale to measure this. For the Rosenberg self-esteem scale, when you get the total score, the higher the score, it shows that this person has high self-esteem. When the score is lower, it shows that the person has low self-esteem. So at baseline, the score was lower at 17.78. And by the midline, when we did this, the evaluation again 6 months later, we had it at 20.94. And by endline, it was 24.39. This cause, these changes at baseline, midline, and endline are all statistically significant. And you can also see the trend line when you look at the graph below, where the internalized stigma is going down and the other one is also going up, showing that negative correlation that as internalized stigma is going up, self-esteem will definitely go down. But as we are reducing the internalized stigma, the self-esteem will go up. Next slide. So I'm going to discuss the qualitative results from this study as well. So one of the male participants said, when I was having the challenge of leprosy, I feel ashamed to go close to people, even my wife and my children. You know, during the ancient times, you will hear different kinds of stories of what happened to people with leprosy. I was thinking that all of them, family members, will be infected with it. That's why I always go far from them. But presently, since the intervention, so when he's talking about the intervention, he's talking about the Calabar experience, the co-creation experience. He said, as I get back home, the first assurance I gave to them is the disease is curable and cannot be transmitted since I am on treatment. Now I am associating with everybody in the community. I am even the youth chairman in the community today. Next one. So this is from a female affected that also was part of the co-creation development. She said, now I feel like I'm a complete human being because back then I used to be afraid of myself because of my predicament. But now when I was educated about the disease and I took my drugs constantly, I now know that I am also a human being. I can easily mingle with colleagues, friends, and relatives. Next one. Before, there were a lot of things that were said to be the cause of leprosy. Only God knows. And they even said, if you offend someone, that he will infect you with the disease. And for us that came from the riverine area, they mentioned that a certain fish caused leprosy. Since I came here and was sensitized and understood better, I went back and used what I learned to educate the community, and I was accepted because I am one of the community leaders. And because of this, I feel I have progressed. This is from one of the patients. And one thing we need to see from their responses is that there is kind of poor knowledge about leprosy. And because of that poor knowledge, it made them feel that what these people have said is actually true. But coming for this exercise helped them to gain better knowledge about leprosy disease, about themselves, and it empowered them to go back and feel better about themselves and even interact and even advocate within their community. The next person, this one is from a female participant. She said, the way I see myself now since completing the treatment is not the way I used to see myself. This time things has changed because I no longer feel alone. This year I'm able to go to farm. Also, people who previously rejected me, I also reject them now. Why those who were close to me when I used to be ashamed of myself, I have maintained a close relationship with them. So this is an example of someone whose self-esteem has come up. So if you feel you cannot relate with me before now, I think this is a time you can stay. Let me be on my own as well. So that's quite interesting. So this one is from a male participant. She said, I noticed is that the level of, what I noticed is that the level of awareness has increased, especially in my area since the intervention. Back then, if I walk into someone whom I see that has some rashes, to tell the person that this is not the signs of leprosy, they will not agree with me. But now, as I'm talking to you, I was able to refer 7 people to Federal Medical Center, a tertiary hospital, as a result of the knowledge I gained during our last co-creation workshop. So people are beginning to know more about the disease. Next one. Before I came here to be educated about the leprosy disease, people of my community used to speak insulting words to me because of my condition. But after the last meeting, I went back home. I didn't bother again with words they said to me. This is quite interesting. Remember what I said, that when those negative stereotypes, beliefs, it all depends on what you want to do with them. a lot of them was opinions would definitely fly around. But when you internalize and endorse them, that is when you have the problem. So if you hear what he's saying, he said, because of my condition, but after the last meeting and went back home, I didn't bother again with words they said to me because I have been educated about the disease and its mode of transmission. So I have been educating others as well. And I'm happy to be here today again. So this is quite interesting, really. So you notice that from their stories, it is not where they started that they are after the participatory co-creation. And looking at analyzing the participatory co-creation, because just like I said, I witnessed it firsthand. I was there to facilitate some of the discussions during that participatory co-creation. And if you ask me, I can say that there are three things that actually contributed to the changes that we are seeing in these people. One of them is psychoeducation. Just like I said before, some of these things are actually fueled by poor knowledge. So when these people don't have accurate information about their condition and about who they are, it kind of makes them to internalize whatever it is others are saying about them. And they believe that those things are true. And because of it, they stigmatize themselves. They ostracize themselves. You notice that one of the women, when she was giving her testimony, sometimes they are the ones that feels that if I get close to these people, they won't accept me. So they will, on their own, withdraw from participating in social events and all that. But during this co-creation exercise, one of the things we tried as much as possible to do is to try to refute some of those negative beliefs, try to provide them with correct and adequate knowledge about leprosy. What is it that causes leprosy? How is it transmitted? How is it treated? And by the time we finished providing those information, they had the opportunity to ask questions. And during those questions, some of the misconceptions they had, we were able to clarify them. In fact, during that session, we even gave them opportunity to tell us about the myths, the cultural beliefs surrounding this situation, this leprosy in your area. And as they are bringing it up, we are trying to discuss it, trying to show them that these things are not correct. So it actually helped them. And they tried, and they now started seeing themselves in a different light. It is not what people think about them that, you are not supposed to be part of us. Leprosy is a source of witchcraft. Leprosy means that you are cursed and all that. So they understood that they were not really cursed. It is not witchcraft. And they now felt better within themselves that they are actually human beings like every other person. The other thing that I also believe that actually helped in creating this change within those people is the peer support. This project, this co-creation development lasted for 7 days. During that 7 days, they had the opportunity to share experiences. It actually provided opportunity for some of them to let out bottled up emotions. Really, one of the women, not Mama Bassi, the one that spoke before Mama Bassi, during one of the days when she was sharing her experience, she was actually crying. How she felt and how people treated her and all that. But during that co-creation development, they had the opportunity to share their experiences, let out those bottled up emotions. They had the opportunity to hear from others, and they knew that I'm not the only one in this. Others are passing through the same thing. So they felt it was more like a psychological healing for them, a way to open up and then let out those emotions. And I can tell you, by the end of the 7th day, they were really happy, waxing song for us, dancing and all that. So another thing that also I believe that contributed immensely to the change we saw in those people is the participation. So one thing about participation, or the other speakers have also said things, something around this, is the empowerment it actually promotes within these people, because you make them feel that they are not just passive recipients of these services. They are human beings. They can contribute to what is happening. It helps them to increase their control, because when they are involved, when they got involved in this, it helps to foster their self-confidence and they believe that they can actually give something to the society. It helped them to ask, say, yes, I have something to contribute. We boosted their self-esteem. You can hear it from their own testimony that they went back. Some of them became health advocates, teaching, talking to people about leprosy, no more ashamed of themselves, and showing that, see, what I thought about this condition before, it is not what it is, because now I am empowered. I am participating. In fact, I'm even the one helping you now. I am the one providing solution to you now. So better come, let me show you where you are going to get treatment. So them participating in this actually helped to boost their self-esteem, increase as in boost their self-worth, and they feel that they are human beings. They can actually contribute to the society. So for us, these are the things we felt that the participation in this co-creation development has actually helped them to achieve. So in conclusion, I want to say that this participatory co-creation was very, very impactful, and it actually helped these people to change their perception about themselves, gain more knowledge, and overcome, just like I said before, some of them came in there gloomy, sad, and their mental state was actually low. But by the time they left, they felt good within themselves. Burdens were actually lifted, and they actually felt that I can go back to the community and give to the community. So the participation of persons affected by leprosy had a significant reduction effect on their self-stigma and positive effect on their self-esteem. And this underscores the importance, just like Dr. Murphy talked during the co-creation when she was doing her presentation. There is need that we involve these people in whatever we are doing. And the maxim by the persons with disability is always nothing about us without us. So whatever we are doing, because they understand themselves, they understand their situation, they understand better. And we cannot, in our various offices and where we are, develop intervention that will fit them properly without their input, without their contribution. And even currently now, they are serving as health advocates within their different communities. This is what we cannot do sitting down in this office, but because we have empowered them, this will contribute to sustainability, because they will continue the good work within the communities where they are. And we may not be able to be there all the time, but they're always within that community doing what they know best to do. So thank you very much. Dr. Nwafo, over to you.
Thank you very much, Chinwe Eze, for this insightful presentation. You can see you ended by saying nothing about us without us. This is about inclusion. What this is telling us is any service or intervention we want to provide for a group of persons, especially the marginalized group, we should ensure that they participate in the design, in the implementation, monitoring, and the evaluation. That is where it will impact on them and then the community where they come from. So at the end of the day, the intervention will be sustained even when the project has ended. This is a typical example of that issue of participation involving of meaningful, not just meaningful participation and meaningful involvement of the persons affected by leprosy or marginalized groups. You plan to provide any intervention, any health intervention, or as the case may be. Thank you very much. Our time is fast spent. So we're going to do two things at the same time. We want to thank all our panelists and all the speakers. We are going to form a panel, have a panel discussion now, and we'll combine it with question and answers. So all the speakers, and then if you have the focal person for national focal person for leprosy, BU, and then the two states who are either here, they should please join in the panel discussion. And then our audience, please, if you have any question for any of the speakers, they are very free to indicate. Either you put it in the Q&A chat box, or you can raise your hand and be given the floor. So we're going to expand the conversation, around how to tackle disease-related stigma in public health through innovative health communication. We're looking at impact, challenges, opportunities, and recommendations. We suggest questions. So we want to expand it further. Public health is not only just now related to leprosy and so on, but I may start by asking the first question to the panelists to say, please, can we, any of us or some of us, tell us, why is effective communication crucial in addressing leprosy and other neglected tropical diseases? Why is it necessary to have, to be discussing matters like effective health communication in dealing with these diseases, neglected tropical diseases, including leprosy? Over. Any of the panelists can please, because our time is fast spent, but we need to expand this conversation.
Okay, maybe let me start, Dr. Nwafo. Thank you very much for the question. So really, effective communication is very essential in addressing leprosy and other neglected tropical disease, because as you can hear from my presentation, one of the key things I observed during that co-creation and throughout this research process is the poor knowledge about leprosy among these persons affected by leprosy, and not just among them, but also within the community. So, and I think that is actually what is fueling most of the stigma and discrimination that is meted out against persons affected by leprosy. So what will effective communication do? Is actually going to raise awareness about leprosy within the community, make people understand, have a better knowledge of what causes leprosy, how it is transmitted, and how it can be managed. Let them dispel those myths, those misconceptions they have about it. And when we are able to raise this awareness within the community, you find out that it's going to result in the reduction of stigma and discrimination as well, and also help with early detection of leprosy. Because one of the challenges we have with leprosy is late detection, with people coming down with disability, grade 2 disability. And grade 2 disability is one of those things that is also fueling stigma and discrimination among persons affected by leprosy. So if we are able to communicate effectively, educate people so that they get to know what leprosy is all about, one, it is going to help in dispelling a lot of misconceptions, helping people to also identify when they have leprosy, and help us also to reduce stigma and discrimination. And in addition to that, a lot of people, due to stigma and discrimination, may not really want to adhere to their medications, because when they think of going to the health facility to pick up medication from time to time, you discover that they will think in themselves, if I go there now, they will see that a patient affected by leprosy, due to the stigma associated with it, they might start the medication, but they may not complete. So effective education, effective communication can help to actually resolve some of these things. Thank you, and over.
Very good. Thank you. Please, the CEO, please, can you mute your device? All right, thank you. Sorry, I don't know if any of the panelists, has anything to.
My hand is up.
Okay, fine. Okay, Tahir, Dr.
Yeah,
Tahir.
in addition to what Chumwe has rightly pointed out, I mean, if you can take a leap from this current intervention, I mean, during the co-creation, one of the co-creation, when the persons affected came into the hall, they looked so down and they were as if they were afraid, as if they were going to catch them and take them to court. I remember in our own group in Jalingo, the guy that came from national program that was with us, the last day of the co-creation was asking, what happened? These people have transformed from being very timid, being, I mean, so scared, but now actively talking and so on and so forth. So communication does not only include talking, but rather verbal aspect of it is also important, and how we relate with individuals. You tell them, they see you doing it, and you actively also show them that this is the right way to do it, and the way to do it, and this is the correct messages. And once that is internalized, I think it will go a long way in changing the perception at all levels. For the community aspect, we are yet to evaluate the outcome of the participants, the audio or written. However, when we get that result, we will be able to say, okay, this one is a better option than this one. If, for instance, if we have the result already, I don't know whether Dr. Murphy can give us a kind of a preliminary brief on which was showing better outcome compared to comparing the two intervention arms vis-a-vis the control arm. We will be able to say much. But from the way I look at it, and from our own field visits, the audio seemed to provide more, good results than the written material, depending on the target audience we are addressing. Thank you.
Thank you very much. Any other question or answer from any of our participant audience? Otherwise, I would like to ask us, now that we have heard about the co-creation and, in other words, the participation of those affected in creating the materials, and you have also heard from the presentation, both from the testimonies and from the presentation made by Chinwe, by the lessons, the outcome of that process. Do you think we need to rethink our strategies for effective health communication for disease control in Nigeria? In other words, do you think there's need to rethink the way we carry out our health communication in the country across diseases? Any person can take up that.
Thank you so much. Yeah, thank you so much, Dr. Mako, for that question. It's really a very apt question to ask, given all of what we've seen so far. I'm just happy to throw a little bit of light on that, because though I'll start off from the premise of what Dr. Tahi said as well, because quite frankly, as it is now, we have the comprehensive results of the impact of this intervention on persons affected, but we are yet to do the full do the analysis of the effects of audio versus written, which was a more effective medium of communication in the community. So rather than speculate, I won't want to speak to that. But in the context of this conversation, what I would like to point out, which is also in line with the earlier presentation, I think by Caroline, is the fact that in the way we currently, approach health education using the top-down approach, is probably time to rethink that strategy, which is part of what we are trying to communicate here in this participatory, based on what we've seen beyond the theory now. This is our experience given this context, and particularly relevant for disease-related stigma, such as leprosy, case in point now, because when it's top-down and it's just education you are trying to pass across, information in itself is not enough, to move the needle as far as behavioral change is concerned. I think it's now an established fact. It's not enough to just say this is right or this is wrong or this is the correct info. And then it's bad enough in a context here where is a disease that is riddled with different forms of myths and misinterpretations or misconceptions and all of that. So if you take off that first layer of misinformation or disinformation and all of that, and then you layer on even being aware of the right information, is still not enough. There's still yet another layer, for you to even get the extra level of when people are now involved, they participate, cause stakeholders who are affected by a particular disease entity, like this one we are discussing now, where they actually, become the drivers, get more proactive, determine, okay, this is where the challenge is, these are the issues, and able to now be the one shining a spotlight, because just like the previous speaker, Chinwe, mentioned, the research in itself, this component of research was long done. done with. This is like since last year. In fact, it was, if not for the no cost extension that we got, we originally planned to just do a 1 point post-intervention data analysis at 6 months. And it's outstanding what the result is, that 6 months after, 12 months after, 1 full year after the intervention, without any added effect, these people are now advocates in the community. It's such a big deal, you know. So for me, in response to your question, do we need to retake our strategies for effective communication? I would say yes. Yes, in terms of from the point of creating, you know, an effective health intervention material, health education material, you know, from the point of that design all the way to the way it's implemented, all the way to, and when I'm saying the design, not just the content, the medium, how it's communicated, how best, you know, just like they were saying in the video, you know, they literally dramatize this thing, and what we were there to do as research people, facilitators, was to document what they were saying, how best they thought this should be communicated. You know, so we did dramatize it, we documented, and that's how we came out as those infographics and animations. So yeah, my answer is an absolute yes. Thank you.
Very good. It's good to hear that. At least this has shown us that there are ways we can improve on the current way we communicate health information or disseminate health information. So it goes down to say, yes, we need to do things differently, as has shown in this research. I don't know if any of the panelists or any of the speakers, you know, has anything to add to that, or any of our members of the audience.
Well, thank you. I don't have much to add. I think we've heard from the researchers here, and the message is quite clear, very eloquent. I just want to say, generally speaking, for those of us who have the privilege, and it is a privilege actually to be called upon to be the head workers working with this. We have a responsibility, not just to talk, not just to say the things we know, but we should always remind ourselves that actions speak much louder than words. People will be watching us. In fact, if you want to lead, it is, yes, words are important. It's good to say something, it's important, but more important still are your actions. So if you're interacting with persons affected, people are watching. They may not be telling you. If they see that you interact with them like you will interact with persons not affected by leprosy, then they will take a cue from you.
Yeah.
So I think that's all I have to say. That I think we as leaders must be willing to lead by examples. Thank you.
Yes. So yes, we the leaders will have to actually lead. We have to show the way, because if we the health workers stigmatize these persons, then what do you want them to do? Of course, they have to go into their shell. Thank you very much, sir. And so I don't know, the media and community leaders, I don't know the roles and opportunities they have now do they have any roles to play in shifting public, attitude, and then in way to communicate effectively strategies for, communication strategies going forward. The media and community leaders, what role do you think they have to play now to shift attitude, to ensure that there is effective communication in public health space?
Yeah, if I may comment, Dr. Nwafo, the issue is not the medium, but rather the content. How is the content designed? On what basis are we kind of developing the content? Often, as rightly pointed by Caroline's presentation, the practice has been top down instead of bottom up. So I think my own suggestion is whoever is developing anything to change perception or kind of to effectively communicate to people or to the target audience should first find out what are the issues at stake And who are the stakeholders? The stakeholders here primarily should be inclusive of persons affected. The experts very often will come up with some jargons and very powerful grammar that can confuse even the community members. Yes, the community members and the media, they are very powerful, medium or media to kind of cascade down your own communication messages, but the content must be right. The content must be right, addressing the gaps identified. So my suggestion will be, going forward, the SCSM committee will always design something based on evidence, not just based on what experts like you and I will say about leprosy or TB. And then we sit down in Abuja and come up with something, and then we say this will be okay, we start airing it. We need to invite persons affected, they should participate. We only facilitate the process. And once the content is right, community gatekeepers, as well as the medium of communication, that will continue to play an important role. Thank you.
Okay, thank you very much. So if I understand you very well, yes, in creating any content, we need to involve the persons, even involve the media themselves, so that they understand exactly what the people want, so that when they're airing it, they know exactly that this came from a group of persons who are actually affected by this condition. Now, of course, the same thing goes for the community leaders, because if they're also part of the process, they will help to go back and educate their persons, about the conditions, because like as we have found out, poor knowledge is an issue, and community leaders are key in disseminating information, about conditions in their communities. Thank you very much. And I think if we don't have any other questions or comments from anybody, okay, let me ask the question. If you have any other concern, any question, any clarifications, or anything you want to chip in further, please, can you go ahead and do that now before we wrap up?
Dr. Wafo, just to mention, and especially also the communication team to be on the lookout. For instance, I see a hand of Kingsley Halfway, and
Okay.
there are a few people that's in these videos as well who are probably in the audience, and maybe they are struggling to connect. So people can actually maybe drop comments on the chats, and then we could the communication team
Yes.
could help to make them panelists, or at least give them the mic to speak. Thank you.
Yes.
Over.
I'm looking out for hands up. Okay, so Kingsley, please, you have the floor.
Hello.
Hello, Kingsley, go ahead.
Yes, good evening all.
Good
First
evening.
of all, I want to appreciate the panel, the speakers, and all our distinguished speakers for their wonderful presentation. I'm Kingsley Anwese, VLO at Makurdi, Benue State. I want to sincerely appreciate everybody. This webinar has really helped me a lot. And as a VLO, it will go a long way to help me discharge my duties as a VLO in Makurdi, because I will be able to carry out sensitization in a long way, even more than before. So I just want to appreciate everybody for their various contributions. And I pray the initiative should yield a very positive result. Thank you all.
All right, thank you, Kingsley. It's good you joined from Benue State. And of course, you are one of the people that are looking out for, actively searching for persons with leprosy or any NTDs, skin NTDs as a matter of fact. So thank you very much. And like you said, you see, you now have some information you can pass along to your community members when you are sensitizing them about NTDs and leprosy in particular. Thank you.
Very well. Very well. Thank you so much.
Sorry. Yeah.
That man does. Yes.
Sorry, please. John, can you?
I saw them when we were. No, I saw
John,
them.
hello.
When we were driving.
Hello, can you mute your mic, or if you have a question, you go ahead and ask. All right. Let's see. Okay, there's a comment here. It says from Fatola. It says the major problem for me as a communication officer is the cost of spreading such wonderful media documents like you have shared with us in the meeting. Most times there is no budget line for such. I want to know. These days is not always, funds. You can use different means. You can put these, messages it's available in the YouTube. You can put it in the other social media platforms. At least some persons will hear and then can take it over to the other person. The lower persons who don't have access to those media channels. Thank you for your comment. Okay, so how do we intend to share the materials? I think this was recorded. We are going to share it, and so we're going to share the recordings to at least all the participants, and then share them through other media channels, websites, and all that. So just look out for those. Thank you. All right, so we're going to wrap up now. I wish I'm not missing any person's comments. All right, so we want to thank all our speakers and panelists, and I'm sure the DPH must have continued his work, but we thank him for coming. Dr. Chuko, the Deputy Director, representing the National Coordinator. Thank you, Caroline. Thank you, Krisa, Dr. Tahil, Dr. Chuku, Dr. Daniel Ebule, and of course our colleagues, the principal investigator, Ngozi Mofio-Akparachi-Nweze, our Director of Monitoring and Evaluation, and all the participants, the persons affected who joined this call, and those who gave us their recorded messages, experiences. Well, thank you very much for joining in. And like I said before, at the end, when we finish the analysis of the community component of this, we're going to be sharing it with, develop a policy brief, which we're going to take to the Ministry of Health. And we hope that these things will get into our policies, and then dissemination will be wide and used both in Nigeria and outside. So on that note, I want to say thank you for everyone, and we hope that we've gained quite a lot from this webinar. And all right, so we noted the comment. So it says he hopes that the local media will brought in to disseminate these findings. Okay, fine, that is noted. So thank you very much, and I have to, at this point, I say thank you, and thank you very much. Have a good night.
Thank you very much, Igwe.
Thank you very
Thank you,
much,
everybody.
Dr. Mwafo. Thank you.
Thank
you very much.
Bye.
Thank you.
Bye.
Bye-bye.
Thank you, everyone.
Yep.
It was a nice time with you all.
Thank you.
Hmm.